Guys, all these changes can be made later, no? This comes much later and everything. I think we're going to just start. All right, we're just starting in 2 minutes.
Ladies and gentlemen, a very warm welcome to India Health Mission Season 2. Over the years, NDTV has gone beyond daily news coverage to lead impactful campaigns that have driven awareness and tangible change in the health sector. We are now poised to take this commitment a step further with India Health Mission. In its second season, the campaign aims to bring renewed focus to the country's most urgent health challenges, promote preventive care, and foster collaborations across the public and private sectors. And by leveraging its trusted voice, NDTV continues to play a crucial role in shaping a blueprint for Health Vision 2047.
That's right, Sikta. NDTV's India Health Mission aligns with the Government of India's healthcare vision and aims to catalyze a national dialogue on transforming healthcare by 2047. The 5 pillars of health policy as envisioned by Prime Minister Narendra Modi revolve around preventive care, affordable and accessible treatment, early detection, technological innovation, and public-private partnerships. And these are the themes that we will delve deeper into as the day and our summit proceeds. Before we start the first discussion, the panel discussion right here behind me, let me take this opportunity to thank our sponsors who made this summit possible. NDTV India Health Mission Season 2 is presented by Fortis Healthcare, co-powered by Takeda Pharmaceuticals, nutrition partner Herbalife, supporting partners Notan Das Realty, and IDFC First Bank, associate partner Shellcal 500.
All right, Gargi, so it is time for us to begin our first panel. Please join me in welcoming Dr. Chandrakant Laharia, Ishi Khosla, Dr. Ashwini Setya, and Mr. Ravi Bhatnagar, and my colleague Gargi Rawat to moderate the conversation on preventive health, making wellness a national movement. Over to you, Gargi.
Thank you so much for that. If my panelists can please come on stage. Hello. As India marches toward the vision of Viksit Bharat by 2047, preventive health has emerged as a crucial pillar in transforming our healthcare landscape. With rising lifestyle diseases, growing health awareness, and an overburdened curative system, the need to shift focus from treatment to prevention has never been more urgent. And today with me on this panel to discuss this very important issue, we're joined by Dr. Chandrakant Laharia, expert health systems and public policy, nutritionist Ishi Khosla, Dr. Ashwini Setya, gastroenterologist, Ravi Bhatnagar, Director, Corporate Communications and Corporate Affairs, South Asia, MENARP, and Africa, RECIT. Thank you so much all for joining us, and a round of applause for our panel, please. Dr. Laharia, I'd like to start with you when we talk about, preventive health and creating awareness. If you could tell us a little bit about what this is exactly, and also how do we make it more popular in the underserved areas? Because I think in urban areas there is perhaps more awareness regarding this, but we need to take it to every corner of the country.
Thank you very much. And Gagiji, I would like to say special thanks to you because you said preventive health. Prevention is often a word which is very loosely used, and that's why it is insufficiently understood. So when we are talking about health or medicine, we should use the term preventive medicine or preventive health. Now, preventive health or prevention is something which prevent things which have not yet happened. And that's why preventive health is always underrated or underestimated. Curative or treatment is something which gives an immediate result or instant results. That's why treatment is always overrated or overestimated. Now, when we talk about holistic health, and you were talking about 5 pillars, it's important that as a society or as a community, we start thinking of giving equal weightage or giving a due weightage to the prevention, promotion, curative treatment, because all 3 are equal pillars. So I always talk and discuss that prevention, promotion, and prompt treatment are 3 pillars which should be given a due weightage. In fact, if we follow prevention, we can avoid a lot of disease burden. In this context, we know that because this is an era or time of instant gratification, something which will give outcome in the longer run, we really do not give a value. So that's why prevention need to be given more weightage. And very specific example can come from COVID-19 pandemic period. We know that during the COVID-19 pandemic period, when people were asked to wash hands or wear masks, they were not doing so because the benefit was not immediate. But when the disease started spreading, especially in the first and second wave, the preventive approach were adopted. Now, in India, majority of programs and majority of interventions follow prevention as a component. But I would say that even a patient or individual or family are not still adept that prevention is followed. They believe that if you, let me put this point here,
sure,
that there are non-communicable diseases which are rising, and every non-communicable disease, diabetes, hypertension, heart disease, require an essential component of halting those diseases are prevention. But what is the prevention? Prevention is a healthy diet, physical activity, exercise. And now people believe that, oh, I have to go for a gym or exercise every single day for the rest of my life. That is too much to be done. And that's why they think if I fall sick, or people do not wear masks when there is a disease spreading, they think if I fall sick, I'll get treatment. But I think that is a wrong approach. We are living in an era where diabetes, hypertension, cholesterol disorders are rising. If we do not follow preventive approach, it will result in increased burden on hospital. It will increase the cost of healthcare. A healthy nation cannot happen only by the hospitals. It requires preventive approach, and that's why we need to pay more attention. I'll come back to other aspects later.
All right, Dr. Lahiri, and yes, I mean, I think that old adage, prevention is better than the cure, has never been more true than, today. Ishi Khosla, we're talking about preventive care, and there have been campaigns around fitness, health, mental health as well. Do you think these are enough? Are they, getting the right, are they, they're targeting the young people? Are they getting that message across?
First of all, thank you for having me here. And, Gargi, I feel, and I was just discussing it with my panelist over coffee, that there is no dearth of information today.
Yes.
I think we, as a generation, are far more equipped with information, knowledge about food, about diet, about nutrition, compared to our parents, our grandparents, and our great-grandparents. There's so much conversation around food. There is so much information on when you buy food. There is it was never before. We have calories, proteins, carbohydrates, everything listed out there. We have equipment. When we're exercising, we have apps. We have everything today which was never there. But it's not adding up to good health. It is really, on the contrary, we are in a state of health crisis. And whether it's mental health, whether it's physical health, and the generations ahead. In fact, I'm going to quote from a Yale public health expert who has said, the coming generation of children is going to have a shorter lifespan compared to their parents.
Which is so shocking because we'd expect the opposite.
It has never happened in the evolutionary history of mankind. So something is clearly not fitting in. That its information is, it's not lacking, but we are probably not making the right, striking the right chords. And I'm also going to quote from Dr. Mark Hyman, who's a functional medicine expert. And he says, and I think that will sum it up very beautifully, that today we are being fed by a food industry which is not paying attention to health, and being treated by a health industry which is not paying attention to food. And I think this is where we need to understand that food has changed drastically over the last 3 decades. It's really, with the advent of the food industry, we are being fed by an industry which has many, many issues. There are chemical additives, there are processing issues, and the safety of food is certainly questionable. And what I would say is today we are getting fake food. And when I say fake food, we are wanting to take protein supplements rather than increasing 2 eggs or just increasing something more in your diet. We are being fed and being brainwashed that we are inadequate in certain nutrients, and we're just offering, the examples can continue. We are being given margarine in the garb of health food, which is actually artery clogging. And I can list 10 examples. I won't take up that kind of time. But I'm just trying to tell you that we need to change our ecosystem and with respect to our food. To say that our children are not literate, our children are literate and smart and wanting to change. Everybody here is aware of good food and what is not good food. But why is it that it's not adding up? Because there are reasons for it. I'll just give you another example when it comes to managing your food. Food is becoming addictive. The food technology industry is putting billions of dollars to making food addictive. So we are not able to control our cravings. We know that this, say, sugar is bad for us, but what do? We're not able to handle it. So net, I think we need to focus beyond just having campaigns and just having messages and information. We need to understand that the food industry needs to be guided and to be also through policy managed.
All right.
Yes, and not to use trans fats, not to use chemical additives, not to use, and there are.
So there is more awareness now regarding what is going into you and what ingredients are in our products, but it needs to be more widespread. I think
it needs to be legislated.
Policy as well. We do know trans fats. There has been a lot of policy change, regarding that. But
using the right grains, using millets, using rice, using
and we have the millet mission as well, pushed by the Prime Minister. Dr. Ashwini Setia, that brings me to you. We're talking about lifestyle diseases, and of course, Dr. Laheria, you would know about the ticking time bomb, that is diabetes. That's another lifestyle disease that is increasing in the country as people are consuming more and more processed food. But tell us a bit about taking from there to create awareness. We have fatty liver. That has nothing to do with alcohol. It's more to do with the kind of products that are being consumed, as Ishi Khosla said. And there's also environmental factors. There's a lot of plastics in our food right now as well.
Right. Thank you very much, Gargi, for having me on this show, and good morning to everybody. See, I'll take up from where Dr. Laheria mentioned. As far as the community part is concerned, there is a paradigm shift in what the community health was there, say, around 40, 50 years ago, and what it is today. Earlier on, we used to focus on clean, potable water, etc., because it was waterborne disease and vector-borne disease, etc. Now, the non-communicable diseases, that is the lifestyle diseases, also spreading in the rural areas in our villages because of the industry, because of so many other things. The industry is sponsoring so many things and advertising it so vociferously that the convenience foods are available there for everybody to pick up. And these convenience foods are playing havoc with our health. Just to give you an anecdotal example, the inflammatory bowel disease, that is ulcerative colitis and Crohn's disease, has paralleled the advent of fast food in this country. When I was doing my specialization about 45 years ago, at that time, we used to struggle to find one case of inflammatory bowel disease in the whole month or a whole year. Now, in every single month, we are having increased incidence of this. So that is because of the highly processed food. The high sucrose corn syrup is being used in cold drinks, and that is playing havoc with the health in terms of giving more sugar load. And you'll be surprised to know that fatty liver as such has got nothing much to do with the fat intake. It has got everything to do with the sugar intake, right? And in fact, the sugar is #1 villain today.
Yes, we hear this more and more these days, yes.
Yes. So as far as fatty liver is concerned, it will not be an exaggeration to say that it is an epidemic. Although the results of various research figures, they show that it's 30 to 40% of all ultrasounds that are being done will have fatty liver as an incidental finding. My own experience is that it is more than 80%, right? So everybody is having that fatty liver. And what they do not understand is that this is an incidental detection because there are hardly any symptoms which will bring the patient to the doctor. And therefore, you are getting the ultrasound done for some other reason and you pick that fatty liver up. Problem is that it is insidiously progressive disease because it causes inflammation in the liver and then it kind of proceeds on to become fibrosis and cirrhosis and further, in some cases, may also have hepatocellular carcinoma.
And people are landing up in hospital for this treatment, and you're saying this could be prevented had they taken care earlier, and we need to create that awareness
regarding... Not only that, so I would suggest that in case the message goes loud and clear, that sugar must be avoided.
All right, that's something for policy, and that would be something that not many of our corporates perhaps would be happy about. But as you say, it's something that needs to be done. We have to take the bull by the horns and prevent. It's going to build up over the next decade, next couple of years.
See, the corporate and the food industry and the pharmaceutical industry is not going to like what I'm going to say.
Do say it. Yes.
So, see, the thing is they have to self-regulate. Today, they are fooling people by saying this is healthy food. For example, I'll give you a small example of baked beans. Packed baked beans are there, that it is very healthy food and so on. In 400-gram tin of baked beans, there is 20 gram of sugar and so much high salt as preservative.
So I don't know if baked beans are that popular, fortunately, yet in India. I don't think they are. But Ravi, this brings me to
I just gave you an example.
Yes, of course. We're talking about messaging and getting that messaging right. And I'll come to you, Ishi. Tell us a bit about what corporates can do. What can we do at the school level? Reckitt has done so many, campaigns. They've been appreciated regarding, health and preventive health as well. So how can we get more corporates? What can we teach at the school level regarding this?
Thank you, Gargi, for having me here. And a beautiful partnership with NDTV from a decade almost now, more than a decade.
One we're very proud of, yes.
Thank you. So, first thing first is realizing India is a big country. And if you see just Uttar Pradesh as a state having the population equal to the population of the UK. So no fun working with 100 kids, 200 kids, 1,000 kids. We also started with 2,500 kids when we started our program a decade back. And now it's almost 30 million kids to whom we reach out to through our program just in India. Nudges are very important. And the power of partnership brokerage is very important. You need to get the right kind of people to work with. It's a mix of public health experts, a lot of decorated doctors, Padam Shris, Padam Vibhushans, and others. Equally, the school teachers. And the best part, what has happened is the change in the national curriculum framework and how the education policy is shaping up, especially in the schools. Now you have got the things what you can teach in the regional languages more. There is no compulsion to teach the messages in English. There's a big change CBSE has attempted now to talk about sugar in the schools. And very proudly saying we are one of the partners who will be taking the messaging, even we have no relationship with the sugar industry or something directly. But we talk about hygiene at home, hygiene in neighborhood, personal hygiene, hygiene during illness, oral hygiene, and a lot of other things what we teach.
And it's so important to teach children because they take these messages home as well.
And one of my colleagues who's sitting in the audience, she taught me something very interesting, Lois. She told me about self-care. We talk about the preventive healthcare. She said, why not to seed the things in the kids from the lens of the self-care. I asked, what's self-care? She said, basic things like hand washing. Then she said about diarrhea prevention. Then she said about pneumonia prevention and many other aspects. And what typically happens is there is a big role of healthcare providers. I will not say there is no role of tertiary healthcare. There's a huge role of tertiary healthcare also. Because the things what tertiary healthcare can do, preventive, there's a relationship between the two. And we can't negate, like, the top oncologist or the gastroenterologist or, endocrinologist. They are not required. They're equally required, because if, like, we still know, like, with a 1.4, 1.5 billion population in India, messaging has to reach, nudges have to go, everyone has a different lens of seeing the things. My global experience of working on Ebola, MERS, SARS, polio, has taught me one thing is, like, consistent hammering and consistent messaging is very much required.
And you spoke about schools, but in workplaces as well, that messaging has to go across.
That's the most difficult one, because now the workplaces have a lot of Gen Z populations, and then they think like they know everything. And there is so much news which is there, and to filter the right news is very important. Therefore, the credible sources are very much important. So the big question comes, so who all are the credible sources? It's same like, one fine day, a random influencer speaks something about something, and people make it as a trend. So, for example, I have three credible voices in this panel.
We at NDTV know all about, this constant fight of ensuring you're the credible voice in this, this world today of a lot of fake news, fake messaging.
So how to filter the credible and the non-credible ones, and making sure the credible has a bigger shelf life. So if three of the panelists, if they are talking, if, on the Google trends and searches from the marketing point of view, if they will not be high, or if Fortis is a partner, if they have a panel of experts, if they are not at the top, and someone random who has no qualification, no degree, speaking on something which is impacting the millions of life, if those people, so there needs to be a regulation. It needs to be more regulated, because it's, largely playing with the people's life.
No, absolutely. Yeah. And when we talk about diabetes, as we were talking earlier, there's a lot of misinformation available there. There's a lot of, cures that are not backed by doctors, and this is something NDTV has done a lot on. But Dr. Leheria, in the beginning, I asked you about how, we're talking about a lot of messaging in urban areas, but it's rural areas really also that we have to reach. As I said, the ticking time bomb, that is diabetes, other, all the other steps they were talking about when it comes to preventive health. So how do we make it reach our villages, our talukas? Do we need to have more community leaders involved? Do you see, like, the local politicians? How do you see us doing this, getting that messaging across?
I think that's a very important discussion, because most of the time we think that this is urban phenomena, the rising burden of non-communicable disease is urban phenomena. That is not completely true. The reason is that, for example, we know that 1 in every 10 adults in India are diabetic. But then, this is around 11% of India's adult population is diabetic. But then there is another 14% of India's population is pre-diabetic, which means they do not meet the threshold of having diabetic cutoff, but they are at stage where they can develop diabetes. Now, key thing is that majority of diabetic are in southern part of the country, if you look at the map. But in the northern part of the country, there is a big burden of pre-diabetic population. Uttar Pradesh, Rajasthan, Bihar, Madhya Pradesh. This is a rural population. So much of the rural population is currently at threshold of pre-diabetic. If we do not follow current interventions, they would turn into diabetic. So this is a ticking time bomb in a sense. Now, coming to your questions, I think if we remember these aspects, this reminds us that we need to follow both in rural area, urban area approach, or making preventive health as a lifestyle approach. Now, often people think what government should do, what community should do, but I personally think that this is, if you want to make a preventive health as a lifestyle way of living, then it had to be at a multiple level, personal. For example, I often tell people that you should be aware about your weight, having a weighing scale in your household, and if you weigh yourself occasionally, then you know whether you are the right weight or not. So how much sugar you are consuming in the daily life, what is your lifestyle pattern. Bringing awareness at personal level will help you adapting preventive
self-care that Ravi was also talking about. Yes.
Similarly, then family. It's not about the individual alone. If a family is aware that what they are eating, one of the approach which many people advise that at the weekly review of the family, whether they are eating right kind of food, whether they are eating high fat, high salt, high sugar. Do a weekly review of your kitchen in the family, head of the family, or a person who is in charge of the kitchen. Do a review that what are the food items which are unhealthy. Take those out. Then the community level, be it a workplace, making weighing scale available at the workplace, making people aware about preventive aspect, including schools. So all of those things need to be done. But also, I would like to go into, because I do half of my work in policy level, I personally have had this discussion that whether regulation by the private sector or manufacturer will work. There is a scientific evidence that the self-regulation rarely works. There is no evidence on self-regulation will work. Final point regarding policy. If you want to make this lifestyle approach, personal, family, community, society, government, and private sector, everyone need to play a role. But policy level, for example, we need to have a right levers or nudges. In India, we are hearing a lot about front of package nutritional labels. Indian government is talking about star rating of the food. Even an unhealthy food will get a certain stars. There is a global evidence that it should be front of package nutrition label, which are high salt, high sugar, high fat. So we need to, government also need to decide a policy which will be easy to comprehend. And I can vouch, and there is example for Chile or many other country, that if you do intervention in preventive health in one area, it impacts a wider range of services. So government need to work on all aspects. So if you want to make preventive a lifestyle, follow a life course and across the spectrum approach.
Well, definitely this needs to be done, and we'll have the health minister here shortly, and we can ask her also about this.
Permitted to just add one small point with what Dr. Laheria said. Because there's a lot of pre-diabetes burden in the northern India and across India actually. Simple intervention, if people are aware of natural foods which may prevent progress from pre-diabetic to a diabetic state. For example, nobody knows about that we can have haldi. Our usual,
so haldi was something traditionally one had, and now of course the West is bringing it back with turmeric lattes and whatnot.
Natural yogurt is there. Bathua in North India is there. And
even millets.
Of course, millets would decrease your HbA1c, which is the marker for diabetes, and also decreases cholesterol. Millets is wonder food, actually, I must say that. And add to that, there is a recent research which says that if we can have jackfruit, which will have soluble fiber and would reduce the sugar burden, right? And add to that, very important is the daily exercise. And if people are made aware of that, then only the intervention would succeed, isn't it?
That's right. Ishi Khosa, as you said, there's a lot of messaging out there. I would say, but again, we belong to we belong to Delhi, urban parts. There's a lot of awareness, but clearly a lot more needs to be done, and the right kind of information, be it from schools, be it corporate messaging, or even at workplaces. Earlier also you wanted to add something. Do go ahead.
Yes, I just was very amused because I had an example. Yesterday, a patient of mine came in, and I'm talking about messaging, literacy, and all of that. And he came to me with an elderly man, about 70, and he had a big belly. He's diabetic. So he is very, very, very clued into the sugar aspect. And he begins his day with 5 rusks with a cup of tea. He doesn't put sugar in his tea, but he has 5 rusks. So I said, sir, why don't you begin with a bunch, mixed nuts which are soaked and put some raisins in it. He's looked at me, raisins? Raisins have sugar. So I said, what about the rusk? But they are low sugar, they are not sugary. He doesn't realize that that rusk is going to spike up his sugars, even if he's taking 1, and if he can take 12 or 15 or 2-3 tablespoons of raisins, they won't do that. But that communication needs to be made. Food literacy is what I'm trying to say, is very important. Then in the evening, he was having some biscuits, and I said, why don't you have a fruit at that time? Take a sweet fruit like a mango or whatever. Ma'am, mango is very sugary. I said, yes, but what about the biscuits? Ma'am, those are 0 sugar. But, those 0 sugar biscuits are laced with grains which are going to spike your sugar. So this perception, this food literacy has to be done properly and has to be communicated beyond nutrition. We have to now talk about food groups. Nutrition is one aspect, but we have to talk about people choosing so many, say, servings of fruits having that half plate rule, very common sense things that, half your plate on your day should be vegetables and fruits and the rest of it in the other food groups. Make it simple for people. Otherwise, the science is standing upside down. We are making wrong choices. Like I said, we're eating fake food because of the kind of messaging that we are doing. And yes, I think a lot of it can also be prevented by addressing gut health, because that's where all the answers lie. What we are eating is impacting our gut microbiome. And that squarely is where everything is decided, whether we are healthy or we are unhealthy, whether we are making the right choices or no. That means our eating behavior. Our eating behavior is being regulated by the microbiome, which is sitting in the gut, which is impacted by the food. So literally in my practice, I see makeovers in a matter of a few weeks. Their food choices change, their palate changes, their appetite changes, because there are 8 appetite-controlling hormones in our gut. The neurotransmitters, the happiness hormones, the serotonin, the dopamine, all of these are in the gut. And what we eat is going to determine how these are going to be playing out in our system.
Absolutely, and in the long run, how it affects our health. So clearly, preventive health is something that we need to create a lot more awareness about. There is a lot of knowledge out there, but the correct, information is what needs to go across. Ravi, finally to you. So what sort of, as we're saying, the messaging has to be right, media, and of course NDTV has done a lot of this over the decades in terms of, putting across messaging when it comes to health, especially in all parts of the country. But how can there clearly needs to be more of the same. There needs to be correct information, and people need to realize that, as I said, prevention is better than cure.
Thank you, Gargi, for asking me this question. I'm very happy to answer this because first 15 years of my career was just in public health. And this new hat of corporate communication just came a few years back to me. One interesting bit is when I reflect back on my journey, and that was a time of National AIDS Control Program Phase 2 planning workshops. So West Bengal was first of the states which started with the Buladi campaign. Buladi is an elderly Didi who was giving messages to others, other Didis in the communities in West Bengal on HIV prevention. Second thing, which is not just very much related to the public health, but there was a campaign by Breakthrough called Bell Bajao. It was about the intimate partner violence. So that was a second campaign which just, sticks to me and resonates with me so much because that became super viral. Third thing was by the BBC Media Action Trust. That was a ringtone which was to make sure condoms becomes normal, the normalization of condoms. So it was a condom ringtone, which was there, and that was very big.
Okay.
And last bit, now I'm coming to NDTV and Reckitt. When we started, it was a yearly affair. On 2nd of October, we chose the day, we said, let's do Banega Swachh India, just after Prime Minister launched the campaign from the Red Fort. And over the years, we made sure, voices are heard from the community and the right messaging should go. So there are various capsules which are done on each fortnight, what goes out to the people in India.
And simple things like just washing your hands.
That's one of the things. Second is, things like maternal health, things like breastfeeding, things like latching, things like growing up for the young kids, things like, prevention of pneumonia or other aspects. So continuously discussions are happening, and we've also seen there are a lot of places where all the medias can't reach, the mainstream one. Still, India is a country which has a lot of hinterlands. Still, you have a lot of aspirational blocks, more than 500. They need a very different approach, which is, mid-media, or actually reaching out to the media dark areas where, we went to the Sundarbans, we went to Hingalganj, Pather, Pratima, and other places. We even reached out to Jarvas and others through our interventions. So how to actually communicate there? How to take care of the people there? And one is the TV decibel noise. Second is something which is so sticky, which actually happens on ground. One of the examples what I always give is with the Sesame Street, the characters what they have created like Elmo, Raya, Chumki and others.
Yes.
And you know, like how beautiful it is, like the stickiness rates are so high, kids, it's fun for the kids to read about it, and you use various messaging and the media techniques to reach out to the people.
Right,
Yeah,
absolutely.
thank
There's
you.
a need for that messaging. In fact, you spoke of campaigns. There was that one around Ande, that, you know, Sunday ho ya Monday, rose khao Ande. So I think we need something the opposite of that when it comes to sugar and other items that may be more harmful for your health. But thank you so much all for joining us today to talk about this very important issue. And it's an issue that NDTV will take further along with this campaign, India Health Mission. Thank you all, and a round of applause for the panelists.
Thank you, Gagi, and NDTV.
Well, staying with the topic of preventive healthcare, next we have Dr. Ashutosh Raghuvanshi, MD and CEO, Fortis Healthcare, and joining him on the stage for a conversation is my colleague Vasudha Venugopal. Right. Dr. Raghuvanshi and Vasudha.
Well, India's healthcare landscape is at a tipping point as we battle a dual burden of lifestyle diseases and communicable illnesses. It's no longer enough to just treat what is visible. We understand that prevention is emerging as the first line of defense, but what does preventive healthcare truly mean in a country like ours where access, awareness, and affordability remain huge barriers? We have with us Dr. Ashutosh Raghuvanshi, who is the MD and CEO of Fortis Healthcare. Thank you, Dr. Raghuvanshi. My first question to you, sir, I was looking at some of your interviews, and you have been focusing a lot on preventive healthcare. What does this mean in the Indian context? Because in India, we often look at hospitals as places you go to when you fall ill. How has that shift really reflected in the operational style of hospitals like yours?
Yeah, I think there are two parts to this question. And the first one is that most of the systems around the world are designed around illnesses and hospitals. It's curative health is where the focus is. And it is not unique to India, but it's all over the world. And the focus has always been on that side. However, I think in a country like India, where there are two diverse sets of population. We have a rural population which is suffering not only from the exposure to communicable diseases, which are still there. There is still a significant burden. They are also having non-communicable diseases. Incidence is increasing as well at the same time. And at the same time, the urban population where obesity and such things are becoming a real-time problem. So in a country like India, if you look at our healthcare budget, and if we focus that entire budget on the curative side of this, we simply cannot afford as a nation. If you look at the American expense on healthcare, which is about some 16, 17% of their GDP, which is 10 times more than what India's GDP is, and our population is much more than theirs. So that means we simply don't have the resources to try and treat all people. So prevention is an important part. Having said that, prevention is not something new. Preventive medicine has been there for a long, long time. And that's precisely the reason why the incidence of communicable diseases has come down around the world. And there are phenomenal examples. Polio is one glaring example, but there are several other examples of where the preventive part, especially the vaccination part, has, though nowadays, there are a lot of vaccine naysayers as well, but at the same time, I think what has been achieved is phenomenal.
Right.
And we have gone quite ahead in terms of prevention. But different levels of prevention, primary, secondary, tertiary, are required. In India, different set of populations require different set of preventive measures.
Right.
And as I was listening to the previous panel, and there is so much of information around, but all that information is not getting channelized somehow, and it's not becoming actionable at an individual level.
Yes.
So I think we need to focus on that. As far as institutions, especially the private healthcare is concerned, I think there has been a lot of focus on developing preventive care. As we talk further, we can talk about it.
Dr. Raghuvanshi, how does a household prepare for preventive care? Because I'm touching 40s, they tell me that, screenings are very important, but when this whole transformation from a reactive healthcare society to becoming conscious about how can you prevent your own illnesses, how does a household or a family prepare for something like that?
Yes. So I think, one of the things which we have been doing as a company, as part of our CSR, we have got few schools adopted, but these are essentially in rural areas, but the same could be done in urban areas as well. I think if children are taught about self-care and other measures of good health, like prevention, cessation of smoking, taking care of obesity, diet, exercise, all these things, if they are emphasized to children and they understand the importance of it, they carry that message, they grow with it. They take that message to the families. They are the ones who actually are the decision makers.
Right.
In homes today, it is children who decide what has to be cooked. So I think that is going to be a big thing in increasing awareness.
Right. Dr. Raghuvanshi, there's one more word that we keep hearing, and that's wellness. How do we become a society that's, conscious about the diseases that it has, to being a society that is also very, conscious about the aspect of wellness? What are you doing in Fortis Healthcare to bring in that concept? Because when we look at hospitals now, they're becoming happy spaces. You see a lot of diagnostics. There's data that is explained to you. How do hospitals or private healthcare spaces become happy spaces for people to bring in more positivity and not just look at fixing the problems in their bodies?
Yeah. I think that is very important. Wellness is the concept which private healthcare is adopting more and more in different formats. So we also are doing our bit. And in that regard, we have identified few key areas which we think are very, very important and which are underserved as well. So mental health is one such very important area for us. And we have done several measures there. Again, there we have done a school mental health program, which we have been doing for years. We run a yearly quiz on mental health, which has been going on for now, I believe, about 8-9 years. Children participate from all over the country. So the awareness about the mental health increases by that. So that is one of the major initiatives, which is our social initiative, which we do. But other than that, we are also creating an online platform, which is for counseling for people, which is not for treatment, but for counseling when people need to talk and they want that kind of support. That is available 24/7. And the third one which we are doing is to create infrastructure, physical infrastructure, which is for the patients who require interventions in mental health space. So that is one area which we are working for. Other than that, we are creating the wellness centers in all our hospitals. One of the areas in the diagnostic is the genomic sequencing, which is a good predictor of a lot of diseases one may have in future. And that can give rise to a specific preventive plan for an individual, a personalized preventive plan for an individual. So we have this next generation sequencing, which can give the report the same day, so that increases the kind of probability of preparing a kind of personalized plan for an individual. And then we are working on several other preventive checks and all. One of the things which I feel is that the blood tests which are done in a package as a regular check program, those at a point of time have no meaning. So linearity of data is important. So that, I think, is one thing which our national health mission, the digital health mission, would facilitate, because then the linear data will be available, and that would give rise to a more predictive analysis of what the future may hold for a person.
Dr. Raghuvanshi, we also believe that preventive healthcare has a lot of tech-driven approach to it. We have a lot of wearables now. We use smart devices. How does this intervention of technology also help individuals understand the importance of preventive health? And is there data to prove that, because you're using some of these smart devices, has it really helped us to counter some of these lifestyle diseases?
Definitely, there are real case studies on at least two areas which I would like to mention, or rather three areas. One is heart arrhythmias, abnormal heartbeat. There, these devices and the continuous monitoring of that, the remote monitoring of the data, has give rise to a lot of prevention of a lot of deaths and a lot of hospitalizations. Similarly, for patients who have chronic liver failure, if they are monitored with some wearable and some other blood parameters, etc., on a linear basis, that data can also be automatically give information where hospitalizations can be prevented. And third area is in cases of heart failure, where again this kind of monitoring will help, and in renal failure, for example. But these are disease-specific examples of people who are having the disease. Other than that, the wearable is generating lots of data, but that data is going into a black hole.
Okay.
It's not really giving any actionable information most of the time. People are self-interpreting it and making their own conclusions. So I think this ecosystem will develop. Remote monitoring is definitely something which is going to make a lot of difference in geriatric populations, and in younger populations, performance athletes and those areas. It can make a phenomenal difference. So the linearity of data and the data being interchangeable and also being interpreted is important. Okay. But I think with AI becoming an important tool, that ecosystem will develop very soon.
Dr. Raghuvanshi, also what would you tell a lot of people who use AI, ChatGPT to understand what's happening to them, when it comes to preventive healthcare? What is the red line that they need to draw for themselves?
I think one has to understand that these tools are not yet there. They do give an indication, but that indication could be wrong also. At the moment, at the best, you can get 60-70% accuracy, not beyond that, and sometimes even less. Because ChatGPT is going to give you analysis based on what inputs you give. So if your inputs aren't correct, your output is not going to be good. So it's not the limitation of ChatGPT, but it is also the limitation of inputs. At the same time, the tool is a self-learning tool. Yeah. So the more people seek information from it, the more accurate it will become. So at the moment, I feel that its role of artificial intelligence is only in assisting doctors in making diagnosis or getting to some conclusions. But for patients to self-manage based on ChatGPT is a little risky at the moment.
You see a lot of patients coming to you after looking at what ChatGPT is telling them. Do you have to face those challenges of telling them that this is not entirely correct and I'm here, I'm going to tell you what is important?
Yeah, I am not in clinical practice at the moment, so I don't have personal experience like that, but I do keep hearing all the time that this happens, people come with their symptoms. But an aware patient is always better than a patient who's not aware. So I don't think it is a negative that people are doing research on their symptoms on Google and ChatGPT or whatever other tools they might use, because that means they are taking care of their health, and wellness becomes an important part of that. Right. So I think an aware patient is a better patient.
Okay. Dr. Raghuvanshi, also, I mean, a wellness-driven approach, does it work for big hospitals like yours? Because a lot of it is dependent on patients who are ill, who have these severe illnesses. How has it worked for Fortis Healthcare? You know, the shift of going to preventive healthcare from something like, just say, that was centered around illnesses.
So it is not binary that you do preventive care or you do only curative care. Both the areas are equally important. And both will be required. As I was saying earlier, that preventive care has been there for a long time, but it has to become more focused. I think both have to be done. For private setups, it is a challenge to decide because there are commercial interests, etc. However, it is a moral and social imperative on the healthcare industry. Unfortunately, we call ourselves healthcare industry, but we only focus on illness. That should not be the case. We should be focusing on good health.
That's very important. Focus on good health and wellness. While we wrap out of this conversation, we look forward to a 5-part healthcare series featuring Fortis Healthcare on NDTV soon. Here's a look at this partnership which promises to decode the evolving healthcare sector where prevention is no longer a choice, it is a necessity, and wellness is priority, like Dr. Raghuvanshi also said. Let's have the logo now. Dr. Raghuvanshi, what are your thoughts on this logo and on this partnership? And also, you know, a collaboration like this, how important do you think it is for the realm of preventive healthcare?
No, this is extremely important. I think NDTV has been the path breaker. We had earlier a relationship on the organ donation for many, many years. And I think this relationship will continue. I think media's role is very, very important. It brings it into the focus, and it is the information which is reliable information. So that makes it even more valuable.
Absolutely. Thank you so much. Mainstream media is a reliable source of information, and like Dr. Raghuvanshi says, that one has to be really careful when it comes to tools which are still evolving. As we close this conversation, one thing is clear. Healthcare is no longer about hospitals, but it's about habits. Fortis Healthcare, in collaboration with NDTV, brings you a 5-part healthcare series that unpacks this evolution from illness to wellness, from reactive to preventive. Join us as we decode how India's healthcare is not just healing lives, but also empowering them. Thank you, Dr. Raghuvanshi.
It gives me immense pleasure to invite Srimati Anupriya Patel, Honorable Minister of State for Health and Family Welfare, to deliver the keynote address. Her steadfast focus on strengthening primary health care, empowering women and children, and driving inclusive health policies has been instrumental in furthering the vision of Swasth Bharat. We are honored to have her with us today to deliver the keynote address at the NDTV India Health Mission Summit. Ma'am, may I now request you to join the stage.
Good morning, Namaskar. Ms. Vaishali Sood, Senior Managing Editor, NDTV. Shri Akhilesh Sharma, Senior Executive Editor, NDTV. Ms. Sikta Deo, Ms. Vasudha Venugopal, Ms. Gargi Rawat, and all the eminent guests and participants. It gives me both pleasure and a sense of privilege to join you all for NDTV India Health Mission, a platform that brings together policymakers, healthcare experts, and change makers, all of us together, to think about the future of India's health. And by 2047, when India completes 100 years of its independence, it's time for us to ask ourselves, what should the health of the nation look like? And more importantly, how do we get there? Friends, as a government, when we look towards 2047, we envision the health of a country as a system which is resilient, which is inclusive, and which is technology-driven, so that it guarantees access to quality as well as affordable healthcare for all our citizens. And Government of India, Ministry of Health and Family Welfare has already started marching in that direction. Our government took over in the year 2014, and the first thing that we did was to come up with a new national health policy, which was finalized after 3 years of wide consultation exercise. And this new national health policy differs from its predecessor by focusing on a very comprehensive and integrated model of health, which encompasses preventive, promotive, curative, rehabilitative, and palliative aspects of healthcare. So while the earlier policies only focused on disease prevention, disease control, this policy has a much broader scope, and it makes a complete paradigm shift from the earlier policies that were in operation in the country. And the focus of the policy today in India is universal health coverage. And you would agree with me if I say that universal health coverage is a journey. It's an ongoing work. In India, we are moving fast in the direction of attaining universal health coverage. We have challenges, but we also have achievements. But what I can assure you today is that when it comes to universal health coverage, there is both a strong political will as well as an enhanced public healthcare spending. We are trying to strengthen primary, secondary, and tertiary healthcare in India. So when I say primary healthcare, 1,77,000 Ayushman Arogya Mandirs, which we have in different corners of the country and which have become the first point of contact for any ordinary citizen. Today, they are transforming the way primary healthcare services are delivered by offering a package of 12 different services. So going beyond the traditional maternal and child health services which were being provided at these primary health centers, the Ayushman Arogya Mandirs are providing care for NCDs, for mental health, for eye health, for oral health, ENT, first level emergency and trauma care, and also teleconsultation services. We all know that there is a growing burden of non-communicable diseases in the country. And recognizing this burden, Ayushman Arogya Mandirs are today playing an extremely crucial role in their prevention, detection, treatment, and management. Why I say this is because every individual in the country who is aged 30 years and above is today being screened for diabetes, for hypertension, and for 3 types of common cancer: oral, breast, and cervix. And another noteworthy aspect of these Ayushman Arogya Mandirs is that it is providing counseling services for mental issues. Depression, anxiety, stress, all these are very common. Every second individual you meet has some of the other issues. And there is so much of stigma attached to mental disorders or mental issues that people do not want to seek medical help. So at such a grassroots level, Ayushman Arogya Mandirs are making that early intervention and also helping us to reduce the stigma that surrounds mental issues in this country even today. And because these Ayushman Arogya Mandir, as I said before, provide first level of emergency and trauma care, they are also able to reduce the burden that we have in our country on the tertiary healthcare facilities. Ladies and gentlemen, the future of health in India is preventive. And we have that in our national health policy. But how do we take preventive health care to grassroots level? Here also the Ayushman Arogya Mandirs are playing a very important role. How? Because Ayushman Arogya Mandirs are today educating the community and creating awareness among the grassroots levels, community which resides at this level. What is a healthy lifestyle? Awareness about nutrition, hygiene, sanitation. There are yoga and wellness sessions which are being conducted at the Ayushman Arogya Mandir. So we are making an intervention right there so that people move towards preventive health. And one of the key programs in the direction of preventive health in India is the Universal Immunization Program, which happens to be one of the largest in the world, where we vaccinate 2.6 crore newborns and 2.9 crore pregnant women every year. And when we try to prevent diseases through vaccination, we are not just trying to reduce the financial burden on individual and healthcare systems, but we are also advancing long-term health benefits. And I'm very happy to say that we have not just added 6 new vaccines to our UIP, but we have also been able to enhance the full immunization coverage in India to more than 94%. Ladies and gentlemen, we've also made use of latest technology to attain the success of UIP. Government of India launched the UWIN portal to ensure that every vaccination session is being tracked and monitored, and no pregnant woman who's eligible, no eligible newborn is being left out. That is the way we are working. And when it comes to preventive health care, it is not just the Ministry of Health and Family Welfare which is working towards this goal. There are other programs which were launched in the 11 years of our government, whether it was Jal Jeevan Mission, providing clean drinking water to the common citizens, Ujjwala Yojana, clean cooking fuel, constructing millions of toilets under Swachh Bharat Mission, and movements like the Fit India movement, Eat Right India, and now Stop Obesity. These are all efforts which are taking us forward in the direction of preventive health. And that is the way to go if we want to attain universal health coverage. It is also important to pay attention to affordable health care. As I said before, we envision India in 2047 where every citizen has access to quality as well as affordable health care. And when I say affordable, the biggest initiative in this direction has been Pradhan Mantri Jan Arogya Yojana. This is one of the largest health assurance schemes in the world, which provides a 5 lakh rupee health cover to not just the bottom 40% population, but also 4.5 crore senior citizens, also 37 lakh frontline health workers, Asha Anganwadi, and now we've even decided to include 1 crore gig workers. It's a huge scheme benefiting a large section of our population today. And you would be happy to know that this scheme, when it was launched, the intent was to bring down the out-of-pocket expenses. But as on today, 9.5 crore hospital admissions under this scheme worth 1,33,000 crore rupees have been authorized since the inception of Ayushman Bharat PMJ. And not just Ayushman Bharat PMJ, there have been initiatives like the Pradhan Mantri Jan Aushadhi Pariyojana, the Amrit pharmacies, the free drugs and diagnostic initiatives, Pradhan Mantri National Dialysis Program, and many such programs which have all collectively contributed to bringing down the out-of-pocket expenses. And I say it very proudly that in 11 years of our government, we've been able to bring down out-of-pocket expenses from 63% to 39% today. And not just this, we've been able to increase the share of government health expenditure as part of the total health expenditure from 29% to 48%. You may recall the Economic Survey 2024-25, which was tabled in the Parliament. It clearly said that the reduction in the out-of-pocket expenses goes hand in hand with the increase in the public health spending, and it is a step towards attaining universal health coverage. Moving forward, we also envision India in 2047, where there is no lack of availability of specialist doctors. So doctor population ratio no longer remains an issue of discussion. So what do we need to do? We need more skilled workforce. And for that, there has been a huge expansion of medical education in the country. In the 11 years of our government, we have increased the number of medical colleges by 101%. 157 new medical colleges have been built, and now we are even building nursing colleges in co-location with the new medical colleges that have come up. So from 387, we are 780 now in just 11 years. The MBBS seats have gone up by 130%. PG seats have gone up by 138%. And this is the third tenure of our government. And we have promised to this nation that another 75,000 MBBS and PG seats would be added in the third tenure over the duration of 5 years. Friends, it also becomes important today that we make use of digital health and innovative technologies. They prove to be great game changers because they are not just improving the healthcare delivery, but they are also impacting positively the patient care outcomes. And initiatives of the Ministry of Health and Family Welfare, like Ayushman Bharat Digital Mission, which is an effort to create a digital health ecosystem wherein we are providing a unique ID to every citizen in this country. E-Sanjeevani, E-Raktkosh, Telemanas, UWin, CoWin. These are all examples of adoption of the latest technology, which is very important. And going beyond, now we are even making use of medical drones, which is the biggest transformative step because they ensure timely access to essential medical supplies, drugs, medicines, samples, everything on time in the most remote and hard-to-reach terrains. And we all know of the diversity. We all know about the geographical challenges of this country. Just last year, on the 9th Ayurveda Day, Prime Minister Narendra Modi ji, He launched the medical drone services and 11 All India Institute of Medical Sciences. We're also moving ahead with schemes like MedTech Mitra and Patent Mitra, wherein we try to handhold the innovators, give them regulatory guidance, give them clinical validation services, patenting support, and we make sure that a robust ecosystem is created where their ideas could be turned into market-ready solutions. So all these are efforts which are being made in the direction of more and more adoption of digital technology and innovation. And how can I forget artificial intelligence today? 3 centers of excellence have been set up at All India Institute of Medical Science. All India Institute of Medical Science at New Delhi, at Rishikesh, and also PGI Chandigarh. And it is intended to promote the development and use of the AI-based healthcare solutions. And we've already started using them in the TB elimination program, in eSanjeevani. We are making use of the AI-based healthcare solutions. So that's how India is moving ahead. We want science to help individuals. We want technology to bring equity. And when we look at the size of our country, when we look at the huge numbers we have, 1.4 billion, the scale is huge. The levels of disparity are unimaginable. So in such a situation, when we think of the ambition of universal health coverage, public-private partnership becomes very important. The convergence of the public sector intent and the private sector capacities, it's not only desirable, but it also becomes indispensable. And there are so many opportunities that exist for us to converge. There are schemes like Ayushman Bharat PMJ. Now what we need is more and more private hospitals for empanelments. There are opportunities in expansion of medical education, diagnostic services, medtech parks, healthcare startups, everywhere where private sector can come and participate. And even the national health policy talks about the key role that this partnership can play. So I'm only here to appeal to you and to everyone that health is a shared mission. And when we envision the health of the country as resilient, as equitable, as technology-driven by 2047, it becomes everybody's responsibility, whether it is policy makers or it is healthcare change leaders, change makers. It is healthcare practitioners. It is just everybody who has to come together. So all I want to say is, this is a government in which health is no longer on the margins. Health is not a fringe issue anymore. Health is the priority of our government. And in 11 years of Modi government, health has returned to its rightful place as the cornerstone of nation's development and social equity. So let us all collectively march towards achieving universal health coverage and building a stronger and a healthier India by 2047. With this, I conclude my remarks, and I thank NDTV for giving me this opportunity to share the Government of India's perspectives on health and what kind of India we want to see in 2047. Thank you all for being patient. Jai Hind.
Ma'am, do stay on. That was a very inspiring speech, and this is exactly what the NDTV India Health Mission also envisions. You talked about grassroots, you talked about the shared responsibility, and of course the media plays a big role in that. Now, as part of today's summit, NDTV is recognizing a select group of individuals and institutions who've made path-breaking contributions to healthcare in India.
Right, we would request our chief guest, Srimati Anupriya Patel, to please join us for the felicitations. Joining her will be Dr. Ashutosh Raghuvanshi, MD and CEO, Fortis Healthcare. Please. Known as the polio man of India, Dr. Matthew Verghese played a crucial role in the country's polio eradication efforts and runs the last dedicated polio ward at St. Stephen's Hospital, New Delhi. His lifelong commitment to public health has earned him global recognition, including praise from Bill Gates. It is our privilege to invite you to receive this honor for your extraordinary work in eradicating polio and transforming orthopedic care for the most underserved.
Round of applause. Before we let you go, Dr. Verghese, we do have a question for you as well. Dr. Verghese, before you go, we do have a question for you as well, and your work has changed lives. You've countered polio in the country, eradicated polio as well. If you could tell us, when you look back at your journey, if you can tell us some of the, critical findings during your time, during this challenging, campaign that you led.
It's fascinating that I'm really truly honored and humbled by this award. The honor and award, I think, goes to that poor patient out in that remote village with polio who's crawling on the ground. And I think this mission, I used to dream about it. Can we get this disease off this face of this country? When I joined the hospital where I'm working now, there used to be 50,000 new cases of polio every year. 50,000 new in India, and in the city of Delhi, there used to be 3,000 new cases of polio in India. And it is amazing, a partnership between the government, between the Rotary and the Bill and Melinda Gates Foundation helped eradicate this disease from the face of earth, from the face of the country, which is a remarkable achievement. I think looking back, that's what really, really humbles me into thinking that possible when partnerships and when we work together as a team. So that's the most important lesson I have.
Thank you so much for joining us here. And that's exactly what the minister was talking about when she spoke about public-private partnerships. Thank you so much, Dr. Verghese.
Thank you.
Congratulations.
Thank you so much.
Dr. Dhananjay Divakar Sagdeo is being honored for his decades-long dedication to improving healthcare for tribal communities in Wayanad, Kerala. His selfless service reflects his belief that serving humanity is a form of divine service. Manav Seva is Madhav Seva. We're deeply honored to invite you, Doctor, to receive this special recognition for your pioneering work in tackling sickle cell anemia among the tribal populations of Wayanad.
डॉक्टर सागदेव, जाने से पहले एक सवाल आपसे, अगर आप माइक ले पाएं तो। हम सब ये जानना चाहते हैं कि आपका जो विजन रहा है सिकल सेल अनीमिया को टैकल करने का, वो क्या रहा और कैसे आपने इसको मैनेज किया?
Yes, for last 40 years we are working in Wayanad for eradication of sickle cell disease. When I went there, there were so many cases with the symptoms of sickle cell disease, but there was no diagnosis. So with the help of All India Institute of Medical Sciences, Delhi, we conducted the diagnosis and we did a research project in Wayanad for control of the sickle cell disease. So for last 40 years, and actually I am glad that we screened nearly 1 lakh tribal population. And now today also we are continuing. Now our beloved Prime Minister has given call that by 2047, the India should be sickle cell disease free. So my aim with the help of Swami Vivekananda Medical Mission is to make Wayanad district sickle cell disease free. Thank you.
Thank you so much. congratulations and best wishes, Dr. Sabri.
Yes, thank you.
Dr. Lalita and Reggie George founded the Tribal Health Initiative, which has changed healthcare for tribal communities in Tamil Nadu. For 30 years, they have transformed healthcare, maternal services, and health-related services in the Citilingi Valley. Dr. Reggie George, we are deeply honored to invite you to receive this special recognition for your extraordinary commitment to delivering healthcare to some of India's most underserved communities through the Tribal Health Initiative.
But before we let you go, Dr. George, we have a question for you as well. And if you could tell us, what were some of the earliest challenges in bridging access gap in healthcare? And this is something I know you believe very passionately about and a big challenge you see in our country.
Yeah, so we went to Citilingi 30 years back, and so the nearest telephone was 100 kilometers away. So and that is access what we're talking about. There were no roads. There were no all-weather roads. So in rainy seasons, we'd be just cut off for weeks or months. And I went to Citilingi Valley with my wife and my 3-year-old son. So it was very challenging at that time, but we stuck on. Thank you.
Absolutely incredible. Thank you so much for sharing, the challenges that you faced early on. Thank you, and congratulations. Launched in 2014, the Dettol Banega Swasth India campaign by Reckitt has reached 1 million schools across India and continues to generate massive impact in reducing absenteeism by 45%, increasing sanitation practice by 75%. Reckitt's impact is also seen in scaling up Dettol's diarrhea net zero program, saving up to 100,000 lives of children under 5 years. These campaigns have been widely commended from the President of India and His Highness Dalai Lama, apart from global recognition. It's our honor to invite Ravi Bhatnagar, Director of Corporate Communications and Corporate Affairs, South Asia, MENARP, and Africa, Reckitt, to receive this recognition on behalf of his company.
Before you leave, a quick question. Many congratulations, and please keep doing the good work that you all are doing. The question, what role do you see of the private sector in building up the Swachh India and Swasth India?
Thank you so much. We were among the first few organizations which, on the maiden call of Honorable Prime Minister, took this challenge and started with a 100 crore budget in the year one. We started it in India. We were fortunate enough with the leadership of the Prime Minister as well as our global leadership at Reckitt. We could scale up Swachh Bharat mission to 20 countries across the globe. Like you have Clean Nigeria, you have Poricho Bangladesh, you have Clean Indonesia, you have Clean Singapore, you have in Pakistan also we have something which is Hoga Saaf Pakistan. Like that, we have taken this campaign over the globe and looking forward to work more closely. Thank you so much.
Thank you and congratulations.
Dr. Shekhar C. Mande is being honored for championing India's rich scientific heritage and promoting indigenous innovations through science leadership. His work highlights ancient Indian contribution and inspires a vision of self-reliant Swadeshi science for a developed India by 2047. It is an absolute pleasure to invite Dr. Mande on stage.
Congratulations, Dr. Mande. And we have to ask you, when we look towards Viksit Bharat 2047, how can we better integrate our traditional knowledge with modern medicine to create a more healthy public?
First of all, I am deeply honored by this award. Thank you very much. We tend to think that the medicine has evolved only in the last 100 years or so with the advent of new drugs and vaccines and all. We often tend to forget that humanity has existed for more than 100,000 years. And in different parts of the world, different communities have evolved their own ways of tackling different disorders. And that's very true because India being an ancient tradition, we have a very rich system of healthcare, has been a rich system of healthcare, which has evolved over several centuries. And if we make an attempt to understand our traditional practices, the traditional practices that exist in the tribals, with that from the modern perspective, I think the world would be a better place to live.
All right. Thank you so much, Doctor, and congratulations. Thank you. Thank you so much, Dr. Raghuvanshi. Thank you so much, ma'am, for joining us on stage and sparing this time for this very, very important campaign. I'd like to now invite on stage the next panel discussion, which is on affordable health for all. Joining us on the panel are Dr. Matthew Verghese, Dr. Indu Bhushan, Dr. Reggie George, and Dr. Abhinav Akhilesh. And moderating the session is my colleague Vasudha Venugopal.
Hello, 1, 2, 3, 4, 5. Huh.
यार हेलो 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 चेक हेलो
The guests, can you just come up? Dr. Matthew Verghese, Dr. Indu Bhushan, Dr. George, and Mr. Bharti. Good morning. In a country as vast and diverse as India, true progress means making quality healthcare not just a privilege for a few, but also a right for all. From villages to slums, there are people in the country who still struggle to access affordable healthcare, but change is underway, and we have change makers here with us, with government schemes, innovations, and low-cost delivery and community health workers leading the charge. Today, we look at how India is working to ensure that healthcare reaches the last mile and leaves no one behind. We have with us Dr. Matthew Varghese, who is orthopedic surgeon, also known as the Polio Man of India, and we have Dr. Indu Bhushan, CEO of Ayushman Bharat, and we have Dr. Reji George of the Tribal Health Initiative, and we have Mr. Ankur Bharti, Executive Director, Grant Thornton, India. Thank you so much, all of you, for being here. I start with you, Dr. Matthew. 2011 was the last year when polio was registered. A case of polio came in India. That was probably the last year. But for people who have polio, this is for a lifetime. As somebody who has spent a lifetime in public health, how do you look at public-private partnerships? Also, when it comes to dealing with crises such as polio, what are the lessons that India needs to learn?
Thank you. Thank you for the opportunity. The lessons from polio are many. Preventing a disease like polio is a life-changing experience for the family, for the community, for the village, for everyone. So once you're able to prevent it, there are those that were paralyzed, they are still there. So people ask me, do you still see polio? Yes, of course I see polio. Only difference is, when my ward had boys and girls in the same ward, reserved beds, they were taken care of. Today, there's a separate ward for men and there's a separate ward for women because they have grown older. So the only thing is, the difference is, there is older polio patients which handling becomes more challenging. For me as an orthopedic surgeon, correcting deformities in a child is easier. Correcting deformities in the older patient is far more difficult, far more challenging, which means to get access to this facility where care is being given, so the number of experts are gone down. So how many people can deal with an older polio patient? That's also gone down significantly. So there is a need to continue your expertise in this area and at the same time to make it affordable in terms of access.
Right.
A lot of patients come to me when I talk to them, "Kahan se aaye hain? Where have you come from?" Distances are not measured in kilometers. Distances are not measured in hours of journey. The lady tells me, 500 रुपए दूरी से आए हैं डॉक्टर साहब, 500 रुपए दूरी से. There is no mechanism by which this 500 rupees duri for a polio patient means the mother, right, the father, the polio patient, and maybe somebody else who can access the healthcare system better than what the illiterate person can handle. So that 500 rupees duri is 2,000 rupees for 4 people to come to the city of Delhi, live in the city of Delhi without anybody known to them, and eat food from the dhaba outside. When Dr. Balushankaran started the polio ward in my hospital, and when he started the polio ward in the hospital, we used to have all hospitals provide food only for the attendant.
Right.
Only for the patient, not for the attendant. So I realized it very soon, the mother would not get food from there. She shares the food from the patient. So I realized we must provide food for them. But there was no policy on it. I had to convince the management on this, that you have to provide food for the attendant also. Otherwise, what happened, one day I found mother was lying on the floor adjacent to the bed. Why is she lying on the floor? Doctor sahab, wo bahar kha liya tha humne, dast lag gaye. So here is something which we don't think of. No insurance provides for this travel expense. No insurance provides for the caregiver who is caring for the disabled. There is no insurance for that. There is no support for that. No corporate sector, no CSR funding cares for this.
Right.
How do you bridge this gap? That's a challenge.
That's
I'm also
a very
finding a
important
challenge.
Yeah. Dr. George, I was looking at you have a wonderful story and we need to talk about it. You and your wife decided to be in a place where there were very few doctors. In fact, I remember Lalita ma'am's words that I don't want to be the 11th doctor in a place where there are already 10 doctors. You wanted to be doctors in a place where there are none, and you operate out of a very small village in Tamil Nadu, in Dharmapuri. What does public health mean for you? Because you have served the tribal community, one of the most deprived communities of the country, for a long time. When we talk about affordability, access, what does that mean for you? Because you have been serving the most marginalized sections.
Yeah, thank you. Vanakkam. Yeah. Now, public health interventions, 30 years back, and public health interventions now have changed a lot. Because the health situation in the country has changed for the better. So we went to Sithalingi when the infant mortality there was 147 over 1,000. It's now 8. So now our public health interventions definitely has changed over the years. The government has come in a very big way, But the tribals of Sithalingi and the Kalrayan Hills are fortunate that we are there, because the elephant that is never recognized in the room is secondary healthcare. And we have graduated from primary healthcare to secondary healthcare, meaning that we are now not in the tertiary space where you are looking at, neurosurgery or cardiothoracic surgery. We are not in the primary care space, because I think the government has done a fairly good job all over India in terms of maternal mortality, in terms of infant mortality, in terms of malnutrition. But nobody is talking about secondary health care. If I have a hernia, where do I get it operated? If I have an appendicitis, where do I go? If I have a ruptured ectopic, where do I go? Now this whole space, this whole plethora of diseases is now going to the private sector. Because the government's budgeting and policies are now aimed at primary and tertiary healthcare, where they have done a wonderful job, no doubt about it. But nobody is talking about this. And so now we are a surgical care facility, so we have a lot of cases coming. But like I said, they're fortunate that we are there. Why isn't the government now talking? And if we are talking about 2047, we should build up these facilities in the government hospitals. You see, our taluk hospitals, our, even some of our bigger PHCs should have surgeons, should have anesthetists who can deal with these things. And that makes access to these very important. I think that is one thing that we should start talking about. Nobody is talking about it, except people who are working in the grassroots.
Very, very important point. Dr. Indubhushan, I remember when Ayushman Bharat was announced in the budget, we all thought that was a big shift, India becoming a welfare state. And there was a lot of criticism. A lot of people felt that this was just not possible. But now we see Ayushman Bharat expanding. Now, elders, senior citizens above the age of, 70, 80 getting covered. Insurance is also growing. States are coming up with their own models. Objectively, how do you assess the way the scheme has worked, and what has it done for the poor people of the country when it comes to health concerns?
Well, very important question. In 2018, when Government of India and Prime Minister Modi started this scheme, the situation was like this, that if the majority of expenditure on health was out of pocket. So for poor people, if they get sick and they have to go to the hospital, either they had a choice of foregoing the treatment because they can't afford it, or borrow heavily, or sell their assets. And there were studies to show that millions of families were either becoming poor or becoming more poor because of expenditure on health. And so Mr. Modi decided that that is not acceptable, and no one should forego treatment only because they can't afford it, or they should not become poor. And it was a massive scheme covering more than about 40% of the country, more than close to about 50 crore people. And so started in 2018, as the minister was saying, that so far close to about 10 crore treatment has been provided. And if you look at what is happening now, the scheme has become very mature. And every month, 25 lakh treatment, and every year about close to 3 crore treatments are being provided. And obviously, it's a big change. And now there are a lot of studies. It has spawned so many studies, so many PhDs have been done on this scheme, and all of them very clearly show that, of course, things need to improve, but in terms of impact, there has been a real impact. Right. The out-of-pocket expenditure, which used to be about 65%, it has come down to about 38%, half. And in terms of cancer patients, people who are covered by health insurance or from PMJ, they're seeking treatment within 30 days. And similarly, number of people who are getting impoverished almost has vanished. So this scheme, in terms of changing the paradigm, because earlier the paradigm was that we build hospitals, we'll provide services, and people will come and take them. The scheme was that, of course, we'll do that, but at the same time, we'll support people from demand side. When they use services, then the money will flow, and we'll get the private sector into the system, because as you were saying, that most of the tertiary care is provided by the private sector. And earlier, the poor people, 40%, 50% of those were totally out of the ambit of those services. Now, they can go and use those services. So, huge impact, I would say, of the scheme in terms of it's a leap towards the universal health coverage. It has made services affordable for most Indians.
Well, many people say that the fall from a middle-class family to a BPL is often just one illness in the family, and which is what Ayushman Bharat has also managed to address. Mr. Bharti, when it comes to financing, when we talk about health insurance, specifically for senior citizens, they say that, claims bahut zyada hote hain. There are many young people are okay, in insuring their health, and also companies are okay funding them, financing them. But when it comes to senior citizens, how is the public-private partnership working when it comes to medical insurance?
Sure. See, Dr. Indubhushan being besides me, I am not the authority on insurance, but let me try and attempt this. What is happening, and that might not be a great thing about our country, which is happening is not a great thing, which should be eventually for our country, is that health premium for especially senior citizens, private health premiums are increasing exponentially, right? Even corporates are facing the same problem. Their own premiums for the employees' parents have increased, have become 1.5 times this year, I can tell you, right? So that is something which has to be looked at. There would be a time when it would become unaffordable for senior citizens to get health insurance because of the premium rise. We, not so young, but till our age, it is still fine. The policy premiums are still affordable. But once we cross 60, it becomes unaffordable. And every year, it is increasing by up to 50% for senior citizens. So that is a very critical juncture we have reached in. But then insurance companies has to make profit. They can't keep on incurring loss on their health insurance portfolio. That's very important. So where this public-private partnership is working and tremendously working is that with the launch of a senior citizen health policy, government senior citizen health policy, there would be a parity which would be reached between private health insurance and public health insurance. My dad, who is a doctor, he has registered for this insurance, the public health. He is 72 now, and he has registered, right? He has a health insurance of his own from private player also. But then the way premiums are going up, probably there would be a time when most of the senior citizens would not be able to afford. That's where this government policy would be very important and would be critical for this sector, right? Another thing which I wanted to add, and this would answer your question even better, is that the health system of our country, so to say, I keep on telling, is one of the best across globe, not just because I'm an Indian, but it is structured in such a way. So I keep on calling it, and lately, it is a trinity of three things. Layered public health system, which is primary, secondary, tertiary, same layered private health system, But then one additional thing which has come into picture is medical colleges, which have been there for last 10 to 15 years. The sheer number of medical colleges being opened every year. Now, medical colleges in India are in a very different structure. They require large hospitals to be opened up. Fortunately, most of these hospitals, because of their location in rural areas, they are still providing only secondary care, Dr. Georgie was talking about. So most of the medical colleges, both in public and private, which are located in rural area, are only providing up to secondary care. They have not reached the tertiary care level. So that is also creating a layer, and the cost of treatment in even private medical colleges is still much lower than other corporate and private health systems. So given the public health insurance for senior citizen, the private health insurance for senior citizen, who can go into corporate hospitals, and the medical colleges, which the pricing is so low.
Right.
You have an umbrella which covers almost all the citizens.
That's very interesting. Dr. Varghese, one interesting part of your journey is that when you started working on polio, I remember that, I've read upon how you used to have these door-to-door campaigns where you would ask people questions on their social class. A lot of diseases that Indian society has is a product of not just lifestyle, but the social class that we come from, the kind of nutrition we have, the kind of resources we have. When it comes to polio specifically, what was your learning? Because I see you not just as a doctor, but also as somebody who understands society. How was that learning very important for you? And how is the understanding of the community very important when you understand public health?
Yeah, I did a house-to-house survey on disability in 9 villages in the Sonipat district. And I used to go there every weekend. Saturday was spent there with a colleague of mine from IIT Delhi. We would do there doing a disability work. That was eye-opener for me. I realized that these families, they were not extremely poor. And when you read the literature, it's very clear. Extreme poverty, the infant mortality rate is very high. Children do not survive past the mother's breastfeeding era. And once they survive that breastfeeding period where they get protection from their mother's milk for the antibodies that are there, once they start crawling, they get paralyzed. And once they are paralyzed, they are crawling on the ground. And I realized soon the impact it has on their life and in the family's life. The child would be educated to the level of the school available in that school village. So if it is till the 5th class, the child will be educated till 5th class in that particular village. The other village had a higher secondary school till 10th class. The child will be educated till 10th class. And the child will be educated till 12th in the village based on the transport that is possible. So there's a wheelchair. The villages' roads are not wheelchair accessible. So how do you get them to have, those are learnings which I realized. And when I looked at the educational status, each of these children were 2 grades below their level expected. 2 grades below. And education only to the level of the school in that village. So access is a huge issue for the disabled in rural sector. And this was the learning I had from that village study that I did. That's a published paper, actually.
Right. Dr. George, similar question to you. So you and your wife also work on building communities. You help them not just grow turmeric, but also, ensure that they promote them in ways that is best for their own livelihoods. How important is it to have a very community-centric approach when it comes to public health, specifically in communities like the one that you work in?
So, I first worked in a Gandhian institution. So, the whole thing about Gram Swaraj is very important to me. How can communities look after themselves? And so when we started working with tribal women trained, just like our ASHA workers now, but they were illiterate, to start looking at their health. And then we realized that health encompasses so many things. It depends on the food we eat, the money we have in our pocket, the roads you have, the water, whether is it available or not, soil fertility. And then as clinicians, we were flummoxed. We didn't know what to do with all this. So we went back to the community and we sat down with them. And they said that our biggest problem is farming. Our biggest problem is not health. Our biggest problem is farming because farming is a loss.
Yeah.
And we said, okay, I don't know anything about farming, but one of the things I know is that from what I have learned, we should make profits without hurting others, and therefore the only alternative is organic farming. And so we started with organic farming, though many of them didn't believe, but it slowly built up. And farming is something which every tribal can relate to because they do it every day. And therefore, we already had this credibility as doctors and also this farming thing. And one thing led to the other. Farming led to livelihoods, livelihoods led to craft development led to water conservation, led to governance. Actually, the tribals of that area have elected the Panchayat president. She's one of our senior nurses, who is non-political, saying that we want one of us to make the decisions on what our community is, not any political party. And that was a learning for us, over 30 years, how health becomes dependent on so many things and how communities can actually take, things into their hands. They only need this catalyst, like people like us, behind them to do this.
Absolutely.
And if infant mortality, we have not had maternal mortality for the past 15 years. And infant mortality is now much below national average. Now that is possible only with community engagement.
Right.
It is not, you cannot run a hospital and get that.
Absolutely. Dr. Indubhushan, Ayushman Bharat was also very unique because it was partnership, not just with the states, but also with private healthcare, private hospitals. Do you have any complaints with private hospitals? How are they dealing with this? Because Ayushman Bharat concerns the poorest of poor. And private healthcare, but the model itself is in some ways health-driven, but also profit-driven. Did you face any challenges convincing the private agencies in this regard?
So you're absolutely right. One of the key features of the Ayushman Bharat was that it's first time ever that government was co-opting the private sector in the government scheme where we were asking private sector to join hands in providing these services. And if you look at it right now, about 80% of the tertiary care under Ayushman Bharat is being provided by the private sector. And of course, of the about 30,000 hospitals which are impaneled, about 40% are from the private sector. And so private sector is playing extremely important role right now in providing services. And you're right that, private sector initially was slightly hesitant in coming on board because the rates which were being offered were not very high. I would say they were viable, but they were not maybe as high as private sector is used to charging. And we were trying to convince them that instead of having high margin and low volume, you should be looking at low margin, high volume. We'll give you a large number of patients. And so private sector actually told us that, we are okay with the prices so long as you can assure us that our payment is done on time, because their experience of working with other schemes like CGHS was not very positive. And we made it, we actually focused on that the payment should be done on time, because, if we have to have partnership with private sector, we want to make sure that there is something in them, for something in it for them. Otherwise, why would they be participating in it? But in mostly, I think, over time, we also have revised rates, and in some cases we've increased rates. In some cases we thought rates were actually too high, we reduced it. So that process is still going on, and I'm sure that it's still only 7 years, and 7 years is not a long time in a life of a scheme. Over next few years, probably that kind of equilibrium will come where it will be a win-win situation where private sector will also see a benefit in joining the scheme, and government, of course, is very warmly welcoming private sector's participation.
Absolutely. That's something that we all hope for. Mr. Bharti, when it comes to financing, when it comes to health insurance, I see that some states do very well, some states don't do very well. There are states like Madhya Pradesh which seem to be doing well, but Kerala seem to be... So what happens in that regard? Is it the demography that matters here, the kind of people, is it the mindset, or is it just the kind of diseases that impact one state and not the other?
It's also about maturity of health system altogether. At places in states where the health systems are not as mature, people tend to find solutions in other things. You named Kerala, the health system is very mature, especially the primary and secondary health system is highly matured. So people don't see that, insurance would help them much because public health system provides you such great health facility for free. So why to, go for insurance or any other kind of cover? But then states in which the health system is still struggling, and though they are improving tremendously, I can tell you Bihar, UP, I have seen Bihar, Odisha, West Bengal, they have been doing very well now. They are trying hard to reach to other states level. But then since the public health system hasn't matured enough, people try to find solace into other schemes which can provide them that kind of support. I mean, the sheer number of patients who come to Delhi for treatment, both in public and private hospitals, they need some kind of umbrella cover to take that up. So you'll find these things there. And then also there is another component which might not be that important from public health point of view. But then presence of corporates, industries, is another, because they are one of the largest consumers of private health insurance from a group insurance point of view. So you'll find that the largest number of insurance policies sold is in Bombay, right? Across India is in Bombay. Why? Because 40% of your economy runs out of Bombay, and head office of most of the corporates is based out of Bombay. So all the policies are given out of Bombay, right? Mumbai. So that's another reason why you see parity in health insurance distribution across the country.
Right. Mr. Varghese, I know that you've worked in Delhi. While we talk about rural public healthcare and urban healthcare, there's a large portion of urban poor now, specifically in mega cities. How do you look at an affordable public healthcare system for the urban poor who are living in mega cities? And there are estimates that India will be urbanized more and more in the coming years. Do you have a model in your mind that should work very well, specifically when it comes to the poorest of poor people living in cities of the country?
Yes, indeed. It is a challenge because once the infant mortality rate goes down, then those children that survive, they will eventually need secondary, and eventually when they reach 70, they will need quaternary care also. Maybe a stroke, maybe cancer, maybe cardiac. Because eventually as a person grows older, he will need high-end care, will need arthroplasties also. So those are challenges. But the challenge there is, do we have to keep it healthcare as a profit-based or healthcare as an altruistic model? So the moment you bring healthcare as a profit-based model, then the biggest casualty that can come in, to my understanding, is ethics. Ethics. So can we provide ethical care from the private sector as well as from the government sector? So a lot of patients come to me asking for, Dr. Saab, do I need to have this surgery? Just a double check, is it really required? So that kind of a model of ethical care, whether the trust between the doctor and the patient becomes important, is a critical area. So therefore, patients are worried about whether this particular surgery is for profit or is it really indicated. So hospitals like mine, St. Stephen's Hospital, or for example, other hospitals that are there, which are working on this model where the patient is not viewed as a client to make more revenue, but patient is viewed as a person for whom service is provided for. So my hospital, 70% of the beds are general and 30% are private, and we do not have any profit being driven back to anybody else. not to the shareholders, not to the doctors. We are all on salaries, and that's a model which is workable. As director of the hospital, I could run any number of free patients, any number of those patients were taken care of without worrying. So subsidized care for the poor could come from the care in the same hospital from the wealthy patients that are coming and accessing very high-end care. Okay. So both are required. You need to develop the tertiary and quaternary care and high-end care to the rich being provided for while they subsidize for the care of the poor. It is a doable example.
Okay,
Doctor, but you need to look at, are we willing to do that or not?
Okay, Dr. Indubhushan, do you have any comments on that? Because you must have seen how states are looking at this. This balancing act between low-cost health models and also high-end models. Do you think subsidized healthcare also works with private healthcare also, which is profit-driven? Is it workable according to you?
Of course it is. Even in the private sector, we've seen that I don't want to take the name, but Narayana, they provide high quality tertiary level care at low price. And there are some other hospital chains, again, I don't want to take the names, who have done that. But my own sense is, now two things are going to help in terms of reducing the cost. One is technology and AI. And Minister mentioned about telemedicine. It will not be possible for very highly specialized doctors to be present in every village. And they will be there in certain geographical areas. Right now, most of them are in metropolitan cities, but maybe hopefully they'll be in smaller cities as well, but they'll not be in villages. So how to provide those kind of services to the poor who are living in villages? I think telemedicine is going to help, but also AI is going to help. Yesterday, I was in a conference where they were presenting an AI model for oral health where you just take a scan of your mouth and it can tell you if you have any major problems with the teeth or oral cancer and many other things. And so this can be very easily done by ASHA workers and others. And so this AI model can also help in terms of screening large number of people and identifying people who need support. And they can be provided that support using, say, Ayushman Bharat or other things. So I think that is the way to go in terms of through technology, reducing cost and making it more affordable.
So a tech-driven approach can work in the benefit of India's public health. Thank you all of you for joining me on this panel. The journey to universal healthcare is long but also important. With stronger systems, empowered frontline workers, inclusive policies and collaborative innovation, India is surely building a healthcare system that works for everyone, because healthcare isn't just service, it's also a promise that needs to reach every home. Thank you so much. Thank you. Also time for our next panel now. The topic is Future of Health Equity, Innovation, Access and Partnerships. And joining us on the panel are Dr. N.K. Arora, Executive Director, the Incline Trust International. We have Dr. Shekhar C. Mande, who's former DG CSIR, which is the Council of Scientific and Industrial Research. We also have Dr. Sameer Gupta, Senior Cardiologist and Director, Metro Group of Hospitals, and Annapurna Das, General Manager of Takeda Biopharma, India. And Gargi, my friend, will join us.
Are all my panelists here? Dr. Gupta was inside. I hope he's come. Is someone calling Dr. Gupta? Guys, is someone calling Dr. Gupta? I just messaged, yeah. Sorry, we just begin in a minute. And sir, आपसे हमने बहुत बात किया कोविड इयर्स में. Yes, I know. We had everybody like on speed dial. सबके numbers होते थे during that time. And of course, the many shows that we did. All right, Dr. Gupta, please come. Innovation, access, and partnerships as India aspires to build a truly inclusive healthcare system. The future of health equity lies at the intersection of innovation, accessibility, and strong partnerships. India must reimagine healthcare delivery models that are not only cost-effective, but also equitable, ensuring that no one is left behind on the path to a healthier nation. On my panel today to talk about this very important issue, especially if we talk about Viksit Bharat 2047, we have Dr. N.K. Arora, Executive Director, the Inclin Trust International, Dr. Shekhar C. Mande, former DG, Council of Scientific and Industrial Research, Dr. Samir Gupta, Senior Cardiologist and Director, Metro Group of Hospitals, and Annapurna Das, General Manager, Takeda Biopharmaceuticals India Private Limited. Thank you so much all for joining us on this very important issue. And Dr. Arora, I'd like to start with you first. If you could explain to us when we talk about equitable health, what does this mean in the Indian context, and what kind of a role can technology play in this?
So, thank you very much for inviting. Equity, the true meaning of equity actually is reflected in healthcare and how, and I must also say that India's immunization program also is an example how equity can be achieved, and equity can be achieved very well. I mean, just to give an example, that today 93% of our children are fully immunized, and about 6% children who are left, particularly only 3%. Now, that is an example that every child has to be reached for immunization. And you ask, so that's how I define that anybody who requires health care has access and able to not only access, but able to utilize the services. As far as technology is concerned, I think technology is most efficient way of achieving equity in our kind of setups, which has got a very heterogeneous population groups, very diverse geographical aspects and distances. So technology will not only help us achieve equity, but two other things also come with that. Technology helps us to achieve accountability also. And the third dimension is, which was just mentioned, that technology also allows the access to those aspects of healthcare which are normally even not dreamt of. So if I want a super specialist, how do I reach somebody who is in the remote Arunachal village? So technology is the answer and is the cheapest way of quickly achieving or scaling up our equity efforts.
All right, and you know, India should be able to use technology better and better. Earlier we heard the minister also talking about, you know, AI centers that have been set up in the previous panel as well. They spoke about how AI is being used, you know, for to health even at the rural level. Annapurna Das, next question to you. And you know, we've been talking a lot about partnerships and how they can help in this journey of better health for our public. So if you could tell us more about, you know, how you know, partnerships can increase access to healthcare in India.
Yeah, thank you, Gargi, for that question. And it's my honor and privilege to be sharing this, be on the stage and sharing this panel with such distinguished leaders and experts. So on that note, I think talking about equitable access, I think what's important to realize that achieving health equity is a collective responsibility. I think what it makes that as Takeda, we are forging strategic partnerships which are primarily aligned to the national priorities with the healthcare ecosystem priorities. You know, access to medicine, if is as a global pharmaceutical player, is core to our core business strategy. And we primarily work that all our medicines, vaccines are made accessible. We can broaden access to the most people who needs them the most. You know, what Dr. Arora was talking about, that people who need it the most, you know. Fundamentally, I think we work with 3 pillars. Number 1, innovate to impact. Number 2, which is sustainable access, and number 3, which is health system strengthening. Now, if you look at all of these, you can blend different models of partnerships, you know, which can be cost-based partnerships, joint funding in innovation, you know, it can be manufacturing partnerships. So there are different models of partnership. Let me expand all of these 3 pillars. When we talk about public-private partnership for strategic collaboration, I think, again, I will emphasize that they should be aligned to national priorities so that they contribute to healthcare ecosystem. One, I think, as I talked about, that these kind of partnerships can help us in building sustainable and inclusive healthcare. So I'll give you 2 examples. One, that we work with global organizations, international organizations like Gavi, where we can bring, I think we know about kind of how do we create access to vaccines in low-income countries by sustainable procurement and funding. Then the other part is, which is public health education, you know, how we can work in countries to create the right amount of public health education and awareness. And we are doing something like this in Indonesia with the Ministry of Health for dengue education and dengue advocacy. So this is more about strategic partnerships. If we talk about partnerships in the scale for sustainable access, the one which really kind of talks about is tiered pricing. Okay, how can tiered model-based pricing help in driving access? And then you have models of talking about innovative contracting, risk-based contracting for health outcomes. I think these are the potential models for us to work for sustainable access. The last one which I will talk about is about health system strengthening. I think even in the last panel there were discussions about how to really work around that. One of the things that we believe is, that I believe that would be very helpful is working with state governments, state health departments to increase the capacity for clinicians to diagnose, but as well as treat, you know, non-communicable diseases and vector-borne disease. I think that's fundamental, that how you can drive the kind of community. The other piece, the last piece here, is the community-centric approaches. Fundamentally, when access programs are designed with inputs from community, they are far more inclusive, they lead to better outcomes. And that's what our learning. So I'll sum up by saying that partnerships are not enablers. They are just so fundamental to drive the equitable access in a country like ours.
Well, thank you so much. You know, you recounted about so many examples that have worked, and that's what really we need right now to show, you know, that how things are working on the ground. And that brings us to policy. And Dr. Mande, if you could talk a bit about, you know, how we can ensure that we have the correct policies, because what we need is more innovation, and we need innovation that will help, you know, rural parts of the country, underserved parts of the country as well. So how can, be it state governments, be at the central level, how can we help, you know, push for those policies that will create this innovation and technology that can give more equitable health?
Yeah, first of all, thank you for having me here. That's a very important question. If we talk of innovation, we see innovation at all levels across the country, in rural areas, in remote areas, in urban areas, in our households. Everywhere there are signs of innovation there all the time. What our mothers do essentially all day are trying to innovate on their own to make the household very livable and very pleasant. The tech-led innovation is essentially using the technologies, and a larger section of society can benefit by those. By that kind of innovation actually is what we believe would eventually drive the society forward. Now, the first sign of this we actually started seeing some years ago, when institutions such as different IITs and all took the lead and gave some space to the youngsters. For example, IIT Madras, IIT Bombay and all, they set up these technology parks and gave space to youngsters to try out their ideas in scaling up their innovations. Right? That's the key issue. The policy framework for that at that particular point of time did not exist, but soon what was followed was something like Startup India policy and things like that. They came in the last few years. But yet, I would call it still at its infancy, because most of the innovations that we have seen in the last few years have been essentially in areas like making a new app or a new supply system and things like that. That will have to actually change very soon, because we need actually much larger scale up of other kinds of innovation. For example, in medical devices and things like that, how we can actually promote that kind of innovation. Now, the government's role in this is multifold in promoting innovation. Number one, government creates appropriate infrastructure for anyone to come and use. For example, government, in the very larger sense, for example, government lays down power lines, government makes roads, and things like that. But the second thing, when people want to test out their ideas for scaling up and going to an industrial scale, government actually should stay out of it. Now, one of the major policies of government to actually stay out of that, so when kids are coming out of our academic institutes, say IITs, NITs, universities, colleges, these kids are bubbling with ideas. And they actually want to try out their ideas and try to see whether these ideas can be scaled up and a larger society can benefit. And that's exactly where the government actually should step back. It should promote the early ideas by providing certain kind of funds and all, but not regulate those ideas. And
so
if our policymakers
give them a push, but not go,
that's right. Not have any extensive regulations in governing those ideas and innovations at all. So that would be actually a major role for the government to play.
All right, so that's a very interesting point that you made there. Dr. Gupta, coming to you, you're a doctor, you run a hospital as well. So if you could, we're talking about, public-private partnerships, if you could talk about examples that you've seen or where you feel, this could help in terms of, diagnostics and other hospitals as well.
Absolutely. So let me first begin by saying that, for our, the dream of our country is Viksit Bharat, right? 2047, we have to be a developed nation. And I just want to put it out there, we cannot be a wealthy nation if you're not a healthy nation. So health is of paramount importance, and I want to congratulate everyone for bringing up this panel and talking about health, which is a very neglected subject in general. Talking about public-private partnerships, it is, it's kind of an innovation in the healthcare delivery model, right? Traditionally, if you have to build up a hospital, if you want to deliver healthcare, you buy a piece of land, then you construct a hospital on top of that, and then you deliver, you put in manpower and the patients come and that's how traditionally things work. Public-private partnerships come in different flavors, right? Either the government gives you subsidized land, or they give you a pre-established hospital, which is existing, or for that matter, a diagnostic center or whatever. They give you, either they give you a land on which, at a discounted rate or a free rate, whatever, and you construct a hospital on top of that and then deliver healthcare. Or they give you a half-made hospital or a hospital which is not optimally functioning, and then you come in as a private partner and deliver healthcare over there, and then in lieu of this services that you've been given, the land or the building that you've been given, you give a discounted or free healthcare to a certain percentage of the patients who come to the hospital. So that's usually how private partnerships work.
Yes, that's how it works, yes.
And we do have a public-private partnership with the Rajasthan government. We run a hospital in Rajasthan, in Jaipur. It's a 250, 300-bedded hospital called Jaipur Metro Mass Hospital. And we've been doing it now for close to almost 10, 12 years. And it's worked out really well, where we are able to deliver good quality care at an affordable rate to the residents of the area. Now, public-private partnerships also play a very important role in healthcare education, right? One of the biggest challenges we face in healthcare in India is manpower. We don't either have good manpower or we don't have enough number of manpower. And, the government is now coming up with different schemes. I saw some policy work coming out of Uttar Pradesh, where the government is saying that all the district hospitals, we will convert them into medical colleges. And subsequently, we will have so many more medical colleges. The number of the patient-doctor ratio in India, which has scope for improvement, that can be increased. And the quality of that district hospital will in turn also improve, because now there is a medical college over there, there will be better doctors, there will be better staff over there, etc. So I think public-private partnership is a very important and a very key role if we have to get healthcare delivery and equity for all, as was discussed.
No, absolutely. That's an interesting example. I mean, a proposal that you said Uttar Pradesh is making. And I'd like to come back to you, Dr. Arora. We're talking about, how we can have healthcare for all, how we can, use public-private partnerships. What are the obstacles that you see? And earlier during the sessions, we spoke about how certain doctors have, gone and worked with tribals, gone and worked in rural parts, but that is their own personal mission. How can we have more of that? What are the obstacles in, ensuring health for rural India, for tribal India?
So I will continue from where Dr. Gupta left. One of the major at the moment roadblock is the shortage of manpower. And if I give you the figures, it's mind-boggling. In next 20 years or so, we are talking about 2047, we require 30 lakh more doctors. The second is nurses. About 80 lakh nurses, 50 to 80 lakh nurses and other paramedical. Therefore, the shortage is huge. Today, if I look around the whole country, every state health department has 40 to 50% deficiencies. Even medical colleges getting teachers.
As large as that?
As large as that.
Wow.
So that is something, therefore, we have to bring in innovation in terms of skilling our manpower and get them. So this is a huge area where opportunities exist. Infrastructure making is probably a much simpler task. You have to build buildings and others. The second challenge, which currently I feel is, and we are talking about AI, every second phrase is used as AI. But AI needs data for input. If I have to have a predictive models, if I have to talk about risk factors, I have to talk about diagnostics, I need data, and data from India, and data which is representative. If I take data from this crowd, which will not be applicable to my aims in Deoghar, which is a tribal area. So we need data from all over. The second challenge is data quality, and data quality from across the country, particularly from public sector, but private sector also, that data is as invaluable as the other data. And this, again, there is need for technology for seeing that the quality of data is available, it is available in real time. And the third thing is that this way, whatever data is used, it is used as a evidence to take action at local, state, national level. So that's the second.
Right.
The third component, where again technology is, the whole concept of digital health has come in, that we are talking about Aadhaar ID. That means we have electronic health records of every individual, issues of confidentiality, issues of maintaining the, the data is properly used. But the most important is, the once Aadhaar ID and its usage is there, it should be available right up to the level of health and wellness centers, which we call Ayushman Arogya Mandis these days. And technology, again, I find is very, very important. So when I am entering the data, I must also share with the audience that the data collected by our frontline workers is very correct. It's a very high quality. But transcribing it from the register to any portal, the errors come there and all kinds of mistakes occur. So if I have to track, because it has happened several times, for a vaccine adverse effect, if I have to find out what vaccine was given, what was the dose, if I go to this ANM's register, I find exact information, every part of the country. But as soon as data is entered into any portal, there are problems. So technology here is again important, that we need to have the improvement in the quality of data so that we can use.
That's a very interesting example you gave, and where there's some lacuna, and maybe there's there has to be a push for improvement there. But taking from what you spoke about AI, Ms. Das, if you could tell us how Takeda uses AI and what is the long-term plan?
Yeah, so probably I think from the digital technologies or AI is transforming, particularly from making it very personalized, patient-centric, and accessible. For global biopharma like Takeda, I think what we focus on integrating it across channels. Okay, so that we can, whether it's for its internal and external stakeholders as well as for HCPs and patients. I think one of the things, maybe I'll quickly give you two examples. I think the focus is for HCP engagement and education. If you see that, I think what happens, like if AI is able to really give personalized HCP specialty and profile-based evidence to the physicians. It is also, I think, the predictive analytics that you do is able to give the progress of the disease. And as a result, the clinical decisions can be made with that help. This is one big area where we work, and we have tied up with Salesforce, I think, to bring a life science cloud-based model, which gives the AI agents and AI analytics so that the physician, there is a real-time streamlined interactions between physicians with commercial teams, with patient support teams. I think this is a major shift in how AI being used. Right. The other big area is, of course, patient education and patient support. I think this is what the technology plays a role. So I'll give you just one example here. It can be for faster diagnosis. It is for giving better treatment outcomes. So we are working on something, an AI-enabled app for IBD. Okay, so if you know that, which is kind of heavy, this is a disease, and this would help patients to really track their symptoms, okay? Kind of also track their relapse, help them get counseling, get them support. I think as a result of AI and technology, I think it kind of brings the provider and the patients together for that support. I think that there are multiple examples. At the end of the day, the objective is to create that faster, accessible of these treatments to the patients to improve their quality of life. That's most important.
All right, and earlier on, Dr. Mande, I want to come to you. We were speaking about how the burden of disease is shifting from infectious to lifestyle disease as well. So how does this affect our, if we're talking about health equity agenda, how does this change, impact that?
Yeah, indeed, the burden of disease is dramatically changing in the last 20 years from communicable to non-communicable or lifestyle kind of diseases. We also heard in the morning in the panel that even rural areas, this kind of scenario is changing very rapidly. Now, we have already touched upon AI, right? That's one equalizer, democratizer of all kinds of processes. So for example, when Mr. Jensen Huang was here in India 4 or 5 years ago, he gave a talk in Vigyan Bhavan, and he talked about how AI is rapidly democratizing all processes related to our common endeavor, financial markets or the trade or whatever that we talk of, and health is not very far behind. And that's one way to go forward, that how AI very quickly, we adapt AI into our healthcare system is actually our immediate goal to do that, what we should be doing. Now, Dr. Arora very rightly pointed out that most of the data that exists on different kinds of disorders is actually borrowed from the West, at the moment from India. So we don't really know the basal parameters of whom we call healthy, whom actually we say that certain kind of disorder exists in that person. And that kind of data needs to be generated in India very, very rapidly. And wherever data that exists on today's date is on different formats in different places, so it cannot be integrated that very easily. And if we were to develop our own AI models or large language models or something based on this particular data, it should be our urgent necessity to actually get all this data accessible to our AI community, make it accessible, make it uniform, and make sure that this data can be used very meaningfully for the future of the healthcare.
All right, and clearly there is a need, and for this, we're a young country. We have such a, a burgeoning young population. Hopefully, they can be encouraged to think on these lines of innovation. We all talk about startups. Dr. Gupta, anything you'd like to add to that, and where you feel, we need more innovations and how they could help in this Viksit Bharat 2047?
Absolutely. So, we were talking about AI, so I'll just talk two minutes about that. AI is the buzzword, right? Like Sir just said that, from trading to everything else, AI is being, so I think.
So we don't want people to go to AI for their consultancy as well. There's a lot of misinformation also.
Absolutely. So I think AI is what you feed in is what you get out.
Yes.
And that's how AI works. And that's what Sir said, that, what the data that is required to train those models is very important. But, with the various initiatives of our country of getting Abha ID and all the other the digital health missions, hopefully this will all be successful and we'll have a lot of data that can be fed into for predictive analytics, right? Previously, if you think how the car would function, right? Previously, 20 years ago, you would have a car and you would take it for servicing when it would go bad. Then they started coming out with data. You know what? Every 1,000 kilometers, go get the tire pressure checked. Every X amount of kilometers, get the engine oil changed. So prediction started coming into the picture from data. So similarly, can we reach a stage where we can predict that this person has X, Y, and Z things? Can we predict that this guy is going to get this X illness? So can we do something to prevent that illness from happening before it has happened?
Preventive health, what we were talking about
Preventive
earlier.
health.
Yes.
And, AI, I don't think is going to, in healthcare per se, which is so sensitive, so important, I don't foresee it taking away jobs. I see it as your co-pilot. Like when you're driving a plane, there is an autopilot, there is a pilot, and then there is a co-pilot. I think AI is going to be your co-pilot. And I'll give you a small example. I'm a cardiologist, right? So I'm doing angiographies, angioplasties, and all those things. And that there is this technology we use called OCT, which is for improving your imaging during the procedure. And we would do that imaging first, and whatever data, the images that would come out, you would analyze it yourself, and you would make treatment recommendations. And that analysis would take a couple of minutes. Now, technology has come where after you take those images, the machine automatically tells you that there is a problem here, or there's a problem here, or there is a problem there. So it has done your job for you. It has improved the way you function. And similar things are happening in the world of radiology, in X-rays, in CT scans, in MRIs, in pathology labs, wherever images are there. So, this technology is AI is going to be your co-pilot in your journey of treating patients.
All right, that's very interesting. So nothing to be, scared of. It's how we use it really, and use it to benefit our people. Thank you so much. We're out of time. Thank you so much for joining us on this panel and talking about this, about a Viksit 2047, equitable health for all. Hopefully that dream can actually come true. Thank you. Thank you so much. Well, I'd like to invite our next panel now. Thank you so much, sir. Yes. Yes, sir? Yes, I think so. That's why they were told. Thank you so much. Thank you. Yes. All right, sir. Yes, so Dr. Mande. Dr. Mande.
Thank you.
Thank you. Thank you so much. In a world that moves In a world that moves faster than ever, stress has become a part of daily life. But how do we know when it crosses the line into something more serious? Now a panel which brings together experts to decode the early signs our minds and bodies send us, signs that are too often dismissed as just stress. And joining us on the panel are Dr. Sameer Parekh. We also have with us Dr. Bhavuk Garg, Dr. Manushree Gupta, and moderating the panel is my colleague Sikta Dev.
This table is going. This table is going.
फ्रेम बताओ अरे इसको बताओ ना प्लीज
In today's fast-paced world, stress has become a part of our daily lives. Deadlines, personal expectations, family responsibilities. We all deal with pressure, but the important question is, when does daily stress stop being normal and become a serious mental health concern? आज हम बात करेंगे कि मानसिक स्वास्थ्य के संकेतों को कैसे पहचाना जाए और कब ये सिर्फ थकान या तनाव नहीं, बल्कि एक गंभीर समस्या बन जाती है. And also, when should we seek help and from whom? Joining me is Dr. Sameer Parekh, Director, Department of Mental Health Fortis, Dr. Bhavuk Garg, Associate Professor and Senior Consultant Psychiatrist, और Dr. Manushree Gupta, Senior Consultant Psychiatrist. आप सभी लोगों का स्वागत इस मंच पर. Let me begin with you, Dr. Parekh. We all feel stressed at times. When should we start feeling concerned about it and that level of stress is not the usual daily routine stress?
No, I think two aspects to this. Stress is a part of everyday living. It's not possible not to experience some kind of stress related to something or the other. I mean, we are sitting here having a conversation. I mean, I need to have enough stress to have enough focus right now to prepare for it. You would have had your preparation. If you're not stressed enough to plan and prepare, you wouldn't do well. But if you're so stressed that your mind numbs, you aren't able to think, you have a blackout, you fumble, that also is a problem. But stress is a part of our life. चाहे वो हमारा personal relationships हो, workplace हो, academic हो, रोजमर्रा की hassles हो, stress जिंदगी का हिस्सा है. The difference is we all need to have the right kind of coping skills to be able to deal with this stress. ये एक हिस्सा हुआ कि हम अपनी coping skills को इस तरह से रखें कि रोजमर्रा की जिंदगी के stress को manage कर सकें. और वही mental health है. Mental health is recognizing your strengths and being able to deal with the daily stresses of life. On the other side are mental illnesses. And it's important to see them as two different parts. Mental illness, like any other illness,
Physical
needs
illness,
to be treated like how you would treat any illness. You go to an expert, you take medications, therapy, lifestyle, whatever is involved. And for stress, you continue to evolve, learn, be open. And those are the two ways you need to look at it.
बिल्कुल. अब डॉक्टर गर्ग, हम सब ये जानना चाहेंगे कि जो अर्ली स्पेसिफिक वार्निंग साइंस हैं, शायद यहाँ हॉल में मौजूद सभी लोगों को ये जानना ज़रूरी भी है, वो क्या हो सकते हैं जिसके बाद हमको चिंता करनी चाहिए?
I'll take lead from what Dr. Parekh just mentioned. So, like Sir said, that stress is a part of everyday life, and we call that as eustress. And the stress, when it goes beyond the abilities of a person, the abilities till the time the person is able to cope, then it becomes distress. So, you means good and dis means bad. So, all of us, we need that stress to function properly. Till the time we have eustress, our performance becomes optimal. But when it becomes distress, it goes beyond the coping abilities or skills, then it leads to impairment in the functioning. And this is what is most important for us. For us mental health professionals, for us psychiatrists, any kind of dysfunction, be it social or occupational, सामाजिक और व्यावसायिक जीवन पे जब बुरा असर पड़ने लगे, इंसान अपने रिश्ते नहीं निभा पाए, बाहर जाने से कतराने लगे, avoiding meeting people, going to various gatherings and parties, occupational dysfunction होने लगे, काम में efficiency poor हो जाए, absenteeism from workplace, और students के case में academic performance decline होने लगे, right? So when these things happen, then we say that it is now amounting to possibly a mental health issue or a mental health disorder. It's beyond the normal stress of life. Similarly, जो warning signs की अगर हम बात करें, so they will also occur on a spectrum. हम जब stress में होते हैं, तनाव में होते हैं, so earliest thing that usually happens with us is our sleep gets disturbed. Or there may be changes in our appetite. कई बार भूख ज़्यादा लगने लगती है, कई बार भूख कम लगने लगती है. लंबे समय तक हो, there can be changes in weight. छोटी छोटी बातों पे we start getting irritable. बहुत जल्दी चिड़चिड़ापन होने लग जाता है. कोई कुछ भी कहे, we snap very quickly, we reply back harshly, or we are not able to comprehend a situation. Suddenly going blank. Conversation में हम involved है, suddenly our mind may wander. We get distracted very easily. So these are some signs which show that there is some mental health stress, irritability, impairment in sleep, change in appetite patterns, change in weight, snapping easily, right? So all these are indicators or early warning signs of stress. But at the same time, again a word of caution, just having these does not mean कि mental health disorder or mental health issue हो गया है. Only if they are present, which comes to the second part of how we define a mental health issue or a mental disorder, if it becomes persistent and pervasive. जब ये ज़्यादातर दिनों के लिए ज़्यादातर समय रहने लगे ये लक्षण, then we call it a mental disorder, and we have different classificatory ways जिसमें duration defined है. For example, for depression it's 2 weeks, for mania it's 1 week, and so on and so forth. Right. So early warning signs. Yes, there is possible stress. Something needs to be done. Maybe lifestyle modification, venting out, talking to your friends, to your neighbors, to your relatives, to your work colleagues. If it becomes persistent, pervasive, and leading to social and occupational dysfunction, then possibly professional help is required.
Talking about the early signs of stress, and we are seeing nowadays the younger generation, the school-going children are facing these issues. We really want to know what role can parents and teachers play in identifying the stress, the issues which the child is facing at a very early stage.
Yeah, good afternoon, and thank you, NDTV, for inviting me to this very important discussion in this panel discussion. Parenting, yes, and I'm glad you spoke about young children. So it's been known since last 20 years or so through a robust body of evidence, such studies which have been carried out over 50 years, 60 years. They have identified parenting as the most important risk factor for somebody to get mental illness later in life. So we don't emphasize parenting enough, and we are all at sea how to do this job very well. So parenting skills, parenting workshop is very important. And similarly, teachers in later part of childhood become proxy parents. When the child starts to withdraw from his immediate parents, the parental figure, teachers are the next important figure in anybody's life. So it cannot be overemphasized that parents in early childhood and school teachers in later childhood play a very important role in the identification of stress, mental health issues in young children. Now, it has been known for some times that early childhood adversity, any kind of trauma, any kind of abuse, like for example, bullying in school, or any kind of physical or sexual abuse that a child may go through at home or school, is a very important risk factor for mental illness. So when we say how to identify, of course, in young children, the primary marker that has been understood is a fall in academic performance. We often emphasize how the child is doing academically at school. So one of the first markers of any kind of adversity is fall in academic performance. And then similarly, the children are not very good at articulating their stress, their inner emotions. So we gain much information by observing, by free play, right? So how the child is reacting to his immediate peers maybe his friends, if he or she is undergoing any kind of withdrawal, any kind of social withdrawal, he has become irritable, or he has become aggressive or violent with maybe his toys or his peers, that may be one of the first signs of any kind of stress in the child. Right. Thank you.
डॉक्टर पारिक जी, जो बात यहाँ पर कही जा रही है कि जो ट्रिगर पॉइंट्स हो सकते हैं या फिर जो अर्ली साइंस हो सकते हैं, यहाँ ये समझना ज़रूरी है कि अर्ली चाइल्डहुड में अगर किसी तरह का पैटर्न देखा गया, क्या वो तुरंत रिफ्लेक्ट करता है या फिर आपके अडल्ट लाइफ में वो आगे जाके कभी रिफ्लेक्ट कर सकता है?
बिल्कुल, हमारी ज़िंदगी में जो एक्सपीरियंसेस हैं, स्वाभाविक है कि वो हमारे जीवन भर हम पे असर करते हैं, खास करके आई मीन बोथ पॉजिटिव एंड नेगेटिव। और मुझे लगता है क्योंकि सबकी ज़िंदगी में किसी न किसी तरह की परेशानियाँ आती हैं, स्मूथ लाइफ इज़ नॉट पॉसिबल, कैसे मुमकिन है? मुझे लगता है कि सोल्यूशन की बात हमें ज़्यादा करनी चाहिए, और मेरा ऐसा मानना है कि स्कूलों में मेंटल हेल्थ करिकुलम होना ही होना चाहिए। मतलब ये नॉन नेगोशिएबल है। आप फिजिक्स, केमिस्ट्री, मैथ्स, बायो, ट्रिगोनोमेट्री, पता नहीं क्या क्या पढ़ाते हैं। आई मीन सब्जेक्ट शब्द मुझे पसंद नहीं है बहुत, क्योंकि हम जहाँ सब्जेक्ट बोलेंगे फिर ये होमवर्क करवाना शुरू कर देंगे, फिर ये मार्क्स देने शुरू कर देंगे, फिर वो पता नहीं क्या हो जाता है उसका। बट मेंटल हेल्थ करिकुलम होना चाहिए, और मेंटल हेल्थ करिकुलम टीचरों के माध्यम से होना चाहिए, विच मीन्स टीचर्स की ट्रेनिंग हो ऑन मेंटल हेल्थ। बेसिक चीज़ें, अर्ली आइडेंटिफिकेशन, लैंग्वेज, स्टिग्मा, वेलबींग, कोपिंग स्किल्स, किस तरह से आप क्लासरूम को एक आइडियल एनवायरनमेंट बनाइए। देखिए, आप ऐसे समझिए, एक क्लासरूम भी एक छोटा सा एनवायरनमेंट है। अगर आप हर क्लासरूम के एनवायरनमेंट को पॉजिटिव करते हैं तो स्कूल पॉजिटिव होता है, सारे स्कूलों को करते हैं, दैट्स हाउ द सोशल पॉजिटिविटी आएगी। ये तो आएगी नहीं कि कहीं पे हमने यहाँ कुछ कर लिया, वहाँ कुछ कर लिया। सो मेंटल हेल्थ करिकुलम होना ही चाहिए। दूसरी बात मुझे लगता है कि मीडिया लिटरेसी, ये समय आ गया है कि मीडिया लिटरेसी के बारे में बहुत स्ट्रांगली काम करना चाहिए स्कूलों में, खास करके। एक इतना इंट्रूसिव नॉन स्टॉप एक्सपोजर है वेरियस फॉर्म्स ऑफ मीडिया का, कि अगर हम बच्चों को ये काबिलियत नहीं देंगे, स्किल नहीं देंगे, हाउ टू नेविगेट एंड बी लिटरेट टू डू। और तीसरा, पिकिंग अप फ्रॉम व्हाट मानुषी आल्सो सेड, इस बुलिंग पे काम करना ज़रूरी है। एविडेंस है कि बुलिंग एक सिग्निफिकेंट फैक्टर है अडल्ट लाइफ मेंटल कंडीशंस के लिए। तो अगर हम इन तीन चीज़ों पे भी अगर काम करना शुरू करें, आने वाले दशक में हम काम करें इसके ऊपर, तो जब हम एजुकेशन पॉलिसी की बात करते हैं तो बिना मेंटल हेल्थ की तो कोई पॉलिसी हो ही नहीं सकती है।
बिल्कुल।
अभी हम प्रिवेंटिव हेल्थ की बात करते हैं तो बिना मेंटल हेल्थ के प्रिवेंटिव हेल्थ नहीं हो सकता। हम हेल्थ की बात करते हैं, बिना मेंटल हेल्थ के हेल्थ नहीं हो सकता। जितने लोग यहाँ बैठे हैं, जो बाकी सुन भी रहे हैं, आप हेल्थ डिफाइन करिए, और हेल्थ डिफाइन इस तरह से करके दिखाइए, डेयर है, जहाँ पे मेंटल हेल्थ का जिक्र ना हो। आप बोल नहीं पाएंगे, कंप्लीट नहीं कर पाएंगे हेल्थ को। जिस चीज़ के बिना हेल्थ नहीं है उस पर हमारा कितना एम्फेसिस है, चाहे वो हेल्थ केयर प्रोवाइडर्स हों, चाहे एजुकेशन हो, चाहे वर्क प्लेस हो, पॉलिसी मेकर्स हों, मीडिया हो, ऑल ऑफ अस नीड टू अंडरस्टैंड कि हमें स्टेक होल्डर बनने की ज़रूरत है। खाली ये जो थोड़े बहुत एक्सपर्ट्स हैं, इनसे नहीं हो पाएगा। एडवोकेसी की ज़रूरत है, और उसके लिए एवरी पर्सन हैज़ टू बिकम अ मेंटल हेल्थ एडवोकेट।
बिल्कुल, अवेयरनेस की ज़रूरत है, एंड दैट्स व्हाट द होल एजेंडा ऑफ दिस health mission, NDTV's health mission is also. Dr. Garg, what we are talking about is a solution, like Dr. Parekh said, the early identification of a problem can start from school, like it can be part of a curriculum, how the children are tackled at school level. But a lot of this also steps in when you are working, you know, the stress related to the work. So how can HR teams step in and be a big support system for people at workplaces when they are going through all this?
I always say that whenever you have to spread mental health awareness, the basic dictum is that mental health has to move out from psychiatrist's clinic, right? The problem is, and I'm not criticizing the program today, but see, on a panel on mental health, we are three psychiatrists who are sitting here, right? So and here comes in the stigma also. So mental health has somehow been equated with psychiatry, but in psychiatry we are talking about mental disorder. It's more of the disease aspect, and mental health occurs much more proximal to that. उससे बहुत पहले mental health के बारे में बात होना शुरू होना बहुत ज़रूरी है. एंड सिमिलरली अगर हम इसको एक कॉर्पोरेट सेटअप या HR से लिंक करें, so जो mental health literacy and mental health awareness, like we talked about the school curriculum and the teachers becoming sensitized about the mental health issues, similarly various corporate organizations ranging from the HR and all the professionals, they need to be sensitized that mental health issues exist. There is something called as mental health, and when this mental health issue becomes a mental health disorder. So this is very, very important. Most of the places, if someone has a fever, आप बुखार के लिए छुट्टी लेना बहुत आसान है. अगर हम ये कहें कि मैं आज अच्छा फील नहीं कर रहा, आई एम नॉट फीलिंग वेल, कल मेरा थोड़ा सा मन खराब है, इसके लिए मेरे को एक दिन का ऑफ चाहिए, नो वन विल बी एबल टू टेक दैट और नो वन विल बी एबल टू अप्रूव दैट ऑल्सो इन द करंट एग्जिस्टिंग फ्रेमवर्क. सो वो समझ पाना कि येस, एनी वन एट एनी पॉइंट ऑफ टाइम कैन गो थ्रू अ मेंटल हेल्थ इशू. अगेन आई वुड लाइक टू क्लैरिफाई है दैट मेंटल हेल्थ इशू और स्ट्रेस नॉट टू बी इक्वेटेड विद मेंटल डिसऑर्डर. इसी वजह से लोगों में स्टिग्मा होता है कि इस यू विल नॉट सीक हेल्प fearing that you will be labeled as a person with a mental disorder, और वो label आपके साथ हमेशा लगा रहेगा, चिपका रहेगा, and you will be always judged. Your senior at workplace, अरे इसको तो पिछली बार थोड़ा सा डिप्रेशन हो गया था, इसको ज़्यादा काम मत दो, या इसको काम सोच समझ के देना, ज़्यादा डांटना मत उसको. So your behavior starts becoming biased towards that person, either in favor or against the person. So वो understanding और awareness समझना ज़रूरी है, and please also recognize if someone develops a mental disorder, effective treatment is available, either in terms of medications or in terms of therapy. And at present, the medical science and psychological sciences have progressed to a level where we are able to help a person lead a completely normal life in all spheres, be it family, be it workplace, be it academics, etc. So वो समझना और जानना बहुत ज़रूरी है.
जब वो समझ में आ जाए कि मुझे ये प्रॉब्लम है, तब वो इंसान क्या करे? सबसे पहला स्टेप क्या करे? अगर परिवार उसको नहीं समझ पा रहा है, उसके कॉलीग्स उसको नहीं समझ पा रहे, उसके दोस्त नहीं समझ पा रहे हैं, एज एन इंडिविजुअल, इफ आई हैव एन इशू, वेयर डू आई गो? व्हाट इज माय फर्स्ट स्टेप?
See, usually first step, we always say, and our psychology books and psychiatry books, they have a very nice picture, sir would remember, that your first therapist is your friend. The best therapist is your friend and family, right? As a mental health professional, we are taught that the most important part of providing mental health support is being non-judgmental. So any person, we all need to find people around us who will listen to us in a non-judgmental manner and who will not judge us based on our issues and based on our problems. That is the first step. So I always suggest the first step is your friends and the family and any person at maybe your colleague whom you feel will not judge you in any way. If you are not able to find that person, you can then escalate the issue, depending on the level of the issue that you have. So we have a very robust framework in both the private sector as well as the public sector. There are psychologists, there are psychiatrists who are available, at least in the metro cities. You can easily find them on Google, the person nearest to you, or various listings. You can approach the appropriate person as per your logistics which suit you. Similarly, in the government sector, in the public health sector, we have what we call as the National Mental Health Helpline, and that is known as Telemanas. It's launched by it's under the government of India. So it's a national telemental health program under which the number 14416. It's a toll-free number, and anyone at any point of time can call that number. They will be connected to the nearest regional place, and you can seek help in your own regional language. You just need a mobile phone, and recently an application has also been launched. You can use a smartphone app also to seek mental health support. They'll provide you initial support. If it needs to be escalated, they'll get you in touch with the psychiatrist or refer you to the nearest psychiatrist whosoever is available in your area. So that is one way that you can seek mental health support in the public sector.
Just a phone call away, you're saying? You just dial a number and you
just a phone call, toll-free number. At any point of time, you can access that number.
In fact, I think ये ना बहुत ही important aspect है जो टेलीमानस. I come from the private setup, right? So मैं बहुत clearly और confidently ये बात कहना चाहता हूँ that जो टेलीमानस हमारे यहाँ what our government has brought in, टेलीमानस, मुझे ऐसा लगता है कि आने वाले 10-15 सालों में globally it will be recognized as one of the most impactful interventions done at a societal community level for mental health. मुझे लगता है बहुत ही remarkable चीज़ है to be able to do what टेलीमानस is doing. और मेरा बहुत strongly ऐसा मानना है कि when it comes to psychiatry and mental health, the kind of work that's happening now also because of Telemanas and our other government institutes, मुझे लगता है कि private healthcare needs to catch up. प्राइवेट हेल्थ केयर में अगर आप हेल्थ केयर प्रोवाइडर्स देखेंगे तो जो इंटीग्रेटेड मेंटल हेल्थ प्रोग्राम्स होने चाहिए हेल्थ केयर में, वो आपको ज़्यादातर प्राइवेट सेटअप में उतने इंटीग्रेटेड नहीं मिलेंगे. टिक इन द बॉक्स नहीं है साइकियाट्री, साइकोलॉजी टिक इन द बॉक्स नहीं है. और जो दूसरी बात है वो ये है कि जब हम वर्क प्लेस की बात करते हैं तो वर्क प्लेस और स्कूल्स को कंपेयर करें. स्कूलों में मेंटल हेल्थ प्रोविजन इज़ फार बेटर एज कम्पेयर टू वर्क प्लेस. वर्क प्लेस में जो आज की तारीख में हम EAP वगैरह की बात करते हैं, 1%, 2% यूटिलाइजेशन, दैट्स एब्सोल्यूट नॉनसेंस. 10 से 15% लोगों को इन अ गिवन वर्किंग एनवायरनमेंट मेंटल हेल्थ सपोर्ट की ज़रूरत है. अगर वो आप नहीं कर पाते हैं तो वो एक प्रॉब्लम है और हमें वी नीड टू चेंज आवर अप्रोच. मेंटल हेल्थ सोल्यूशंस जो वर्क प्लेस के हैं वो जब तक एंड टू एंड यानी अवेयरनेस से लेके साइकियाट्री इंटरवेंशन एंड थेरेपी तक नहीं पूरा होंगे तो वो सिर्फ टिक इन द बॉक्स बन के रह जाते हैं.
टिक इन द बॉक्स बनकर रह जाएंगे. लेकिन डॉक्टर गुप्ता ये बताइए कि जो बात डॉक्टर पारिक कह रहे हैं कि प्राइवेट सेक्टर में तैयारी है, पब्लिक सेक्टर तैयार है, जस्ट अ फ़ोन कॉल अवे, लेकिन जो समाज में, जो सोसाइटी में जो इसको लेकर स्टिग्मा है, हेजिटेशन है, वो अभी भी दूर नहीं हुआ है. हालांकि आज की जो यंगर जनरेशन है सामने आके कहती है अपने दोस्तों से, अपने कॉलीग से कि मैं इससे गुजर रहा हूँ. वी सी ऑल दीज सुपरस्टार्स टॉकिंग अबाउट इट एंड टेकिंग द लीड इन टॉकिंग अबाउट देयर मेंटल हेल्थ कंडीशंस, बट स्टिल देयर इज़ अ स्टिग्मा अटैच्ड टू इट. देयर इज़ स्टिल hesitation attached to it, be it parents who don't want to talk about what their child is going through it. How do we tackle that?
देखिए, हम इसको पिछले 50 या 100 साल से टैकल करने की कोशिश कर रहे हैं. मेंटल हेल्थ में स्टिग्मा इट हैज़ ऑलवेज बीन देयर और ये हमेशा रहेगा भी. इसका एक रीज़न है, हम बहुत हिट कर चुके हैं इसको, स्टिग्मा को, कि हाउ टू रिड्यूस इट, एंड वी हैव बीन सक्सेसफुल टू अ ग्रेट एक्सटेंट नाउ, एज यू ऑल्सो मैंशनड, कि अब हम और खुले तरीके से बात करने लगे हैं, बिकॉज द अवेयरनेस हैज स्प्रेड, द लेवल ऑफ एजुकेशन हैज स्प्रेड. बट स्टिग्मा होता क्यों है? द मेंटल हेल्थ इज मोस्टली इनविजिबल, राइट? आपको अगर कल को फ्रैक्चर हो जाए, किसी को कहीं फॉल हो जाए, या कोई हार्ट का इशू है या कोई गैस्ट्रिक इशू है, तो लोग घबराते नहीं हैं, बिकॉज इट्स विजिबल एंड द ट्रीटमेंट इज विजिबल. आपको दिख रहा है कि आपको एक प्लास्टर लगा दिया गया तो आपका जो लिम्ब है वो हील कर जाता है. बट वॉट अबाउट मेंटल हेल्थ? व्हेन वी सफ़र फ्रॉम मेंटल इलनेस, तो हम किस तरह का प्लास्टर लगाएं उस पर, क्या बैंडेड लगाएं जिससे कि दूसरा देख सके, कि जो सोसाइटी है वो देख सके कि ये ठीक हो रहा है. सो द मोस्ट इम्पॉर्टेंट टूल टू रिड्यूस स्टिग्मा इज ईजिली एक्सेसिबल इफेक्टिव ट्रीटमेंट फॉर मेंटल इलनेस डिसऑर्डर. अगर हम ये सोसाइटी अप्रिशिएट कर पा रही है कि जो मेंटल इलनेस की प्रॉब्लम्स हैं वो ईजिली ट्रीट हो सकती हैं, तो स्टिग्मा ज़रूर रिड्यूस होगा. And as Dr. Parekh, Dr. Bhavuk mentioned, that Government of India and state governments, last 10-15 years, they have done excellent job in the field of mental health, how to reduce stigma, how to provide easily accessible care. National Mental Health Program was started in 1982 by Government of India. उसको फिर district level पे ले जाया गया, District Mental Health Program. And this has caused stigma to reduce by leaps and bounds. We have psychiatrists, psychologists available in smallest districts of the country now, because manpower की growth पे बहुत ध्यान दिया गया है mental health program में. But still, India is a huge country, it's a continent. तो जो problems हैं उनको psychiatrist या psychologist सिर्फ वो ठीक नहीं कर सकते. We need everybody to be a mental health advocate. And इसी लाइन में, इसी कड़ी में जो गवर्नमेंट ऑफ इंडिया का टेलीमानस प्रोग्राम है, ई संजीवनी, ये क्या करता है? वाई इट इज़ हेल्पफुल इन रिड्यूसिंग स्टिग्मा? बिकॉज उसने जो ट्रीटमेंट है और हेल्प है उसको प्रोजेक्ट कर दिया है टू द मासेस, राइट? सो यू कैन जस्ट कॉल ऑन 14416 एंड द काउंसलर और द साइकियाट्रिस्ट इज अवेलेबल टू यू 24/7 in 20 regional languages in 50 centers across the country. वैसे ही एक और प्रोग्राम है, ई संजीवनी प्रोग्राम ऑफ मिनिस्ट्री ऑफ हेल्थ, गवर्नमेंट ऑफ इंडिया. इसमें भी आप एक ऐप के द्वारा या ब्राउज़र के थ्रू तुरंत एक्सेस कर सकते हैं टू द बेस्ट साइकियाट्रिस्ट इन द कंट्री, गवर्नमेंट सेक्टर में अभी, नॉट इन प्राइवेट सेक्टर. एंड देयर द आपका प्रिस्क्रिप्शन भी वहीं पे जनरेट हो जाता है. सो दीज आर सर्टेन जो हमारे पास टूल्स हैं स्टिग्मा को रिड्यूस करने के लिए. हम हिट कर रहे हैं रोज़, कम हो रहा है स्टिग्मा, एंड वी आर पार्टनरिंग विद ऑर्गेनाइजेशंस लाइक योरसेल्फ एंड अदर ऑर्गेनाइजेशंस. ये सब कुछ हेल्प करेगा. हमको बहुत एम्पलीफाई करनी पड़ेगी आवाज़, तब जाके ये स्टिग्मा कम होगा.
डॉक्टर गर्ग, क्या ये एम्पलीफाइड आवाज़ रूरल इलाकों में जो डिवाइड है अर्बन रूरल का वो वहाँ पहुँच पा रही, क्योंकि ये एक ऐसी चीज़ है जो हमारे ग्रामीण क्षेत्रों में रह रहे लोग उतना ही उससे गुजर रहे हैं जितना कि अर्बन सेंटर्स में हमारे जो नागरिक हैं या फिर हमारे जो पेशेंट्स हैं। तो क्या ये जो इनिशिएटिव्स हैं सरकार की, क्या वो इस अर्बन रूरल डिवाइड को ब्रिज करने में कामयाब रहे?
I'll cover two aspects to your questions. पहला पार्ट रिसर्च में भी देखा गया और हम अपने प्रैक्टिस में भी देखते हैं, somehow रूरल एरियाज में मेंटल हेल्थ इश्यूज एज कम्पेयर टू अर्बन एरियाज उतने सिग्निफिकेंट लेवल पे कई बार नहीं दिखते हमें, एंड वन ऑफ द रीजंस पॉसिबली इज द रेजिलियंस लेवल्स. रूरल एरियाज में अभी भी दैट लार्ज फैमिली सेटअप, the whole village, the whole community is your family, and you have that support system who are standing with you at any point of time whenever you are.
You don't feel alone, there's somebody there for you. You don't feel alone, lonely.
You're not lonely, yes. So somehow that we don't see, I'm not saying it's significantly low, but yes, as compared to urban areas. But at the same time, that does not mean that we will not focus on the rural areas, right? वहाँ पे focus ज़्यादा important है, especially because in current urbanization and migration, people coming from the rural areas when they come to the cities and the urban setup, वहाँ पे आके जो expectations होती हैं, जो reality होती है, that hits and it leads to mental health concerns. So important है कि rural areas में भी awareness on stigma के ऊपर work करना चाहिए. So government की तरफ से the major initiative is like Dr. Manushri mentioned about the district mental health program. So district mental health program के under we have the mental health services at all the districts across the country, nearly covering all the districts of the country. At present the number is 767 if I am correct or not mistaken. So district level say the persons who are there, the mental health professionals, they would go to the rural areas. The community outreach activities are there where they provide both mental health services as well as mental health awareness activities. And they collaborate with the local village panchayats, the local village authorities to provide these services.
Right.
They collaborate with the local ashas, the accredited social health activities, the most basic or the most peripheral worker, health worker in our health setup. Recently, the government also launched what we call as the Comprehensive Primary Healthcare Setup, the CPHC scheme, under which the various sub-centers. The sub-center is the most peripheral or the most basic healthcare service delivery body in our public health setup. So at the level of sub-center itself, the sub-centers have been now renamed as Ayushman Arogya Mandirs, AAMs. So Ayushman Arogya Mandirs, they have now a separate module on mental, neurological and substance use disorders. So it consists of both awareness activities as well as early identification and appropriate referral of persons in the community in the rural areas as well, and linking them with the mental health professionals through telemanas, through e-sanjeevani or direct referrals.
ग्राउंड पर भी ये काम हो रहा है और देश के अंदरूनी इलाकों में भी ये पहुंच है पब्लिक सेक्टर की जो भी सर्विसेज हैं आप कह रहे हैं, और इसका इस्तेमाल भी लोग कर रहे हैं. हम इस पैनल डिस्कशन के आखिरी पड़ाव पर हैं, इसलिए क्योंकि हम इन चुनौतियों का जो सल्यूशंस हैं उस पर बात करने के लिए भी यहाँ मौजूद हैं. तो चलते चलते आप तीनों से, डॉक्टर पारेख शुरुआत आपसे कि मेंटल हेल्थ इकोसिस्टम में जो एक बड़ा बदलाव इस वक्त आपको देश के लिए चाहिए वो क्या हो सकता है, आप क्या सुझाव दें?
मुझे लगता है बहुत बेसिक चीज़ें हैं. एक तो काफ़ी समय कहते आ रहे हैं अनम्यूट योरसेल्फ, बात करिए, जितनी ज़्यादा हो सके बात करिए, टेक्स्ट कम करिए, इमोटिकॉन्स मत यूज़ करिए, शब्दों को यूज़ करिए, वॉइस करिए, वीडियो करिए, पर्सनली मिलिए. ये क्या ऐसी भाषा में टेक्स्ट करते हैं मुझे आजकल समझ में भी नहीं आता, लोग लिखते ही क्या हैं. सो एक तो थोड़ा रिलेशनशिप्स की अहमियत समझिए. मुझे लगता है उसके बिना जो सबसे बड़ी हार्वर्ड ग्रांट की स्टडी थी हैप्पीनेस की, उसने क्या कहा कि मीनिंगफुल रिलेशनशिप्स, तो ना तो वो आपके फॉलोअर हैं, ना वो आपका सोशल मीडिया है, ना वो आपकी लाइक्स हैं, ना वो आपके व्यूज़ हैं. सो मीनिंगफुल रिलेशनशिप्स करें, अनम्यूट योरसेल्फ. और मेंटल हेल्थ एडवोकेसी मुझे लगता है बहुत इंपॉर्टेंट है. आप जितने लोग सुन रहे हैं, बैठे हैं, मेंटल हेल्थ के बारे में बात करिए, मेंटल हेल्थ के बारे में जानकारी स्प्रेड करिए. जब आपके आसपास मेंटल हेल्थ के बारे में बात होती है तो याद रखिए कि स्टिग्मा नहीं करना है, डिस्क्रिमिनेशन नहीं करना है, मजाक नहीं बनाना है, स्लर्स यूज़ नहीं करने हैं. ये बहुत बेसिक चीज़ें हैं. एम्पैथी कोई इतनी मुश्किल चीज़ नहीं है, लेकिन प्रॉब्लम यह है कि हम जिस तरह की ज़िंदगी जीते जा रहे हैं, मुझे तो अब ये डर लगने लगा है कि 20-30 साल के बाद हिस्ट्री का कोई म्यूज़ियम होगा, उसमें बोल देंगे एक ज़माने में एम्पैथी बढ़ती थी. सो ऐसा ना करें तो अच्छा है, खास करके युवाओं के लिए. हम लोगों ने तो जो कर दिया, वी प्रॉबेबली गिवन यू एज बेस्ट ऑफ वर्ल्ड दैट वी कुड हैव गिवन यू. So you can unmess it and unmute yourself. So probably that's the way forward.
Wow, that's the mantra. Unmute yourself. हमारी इतनी young audience यहाँ live audience बैठी है, ज़रूर उनके लिए ये मंत्र काम करेगा. डॉक्टर गुप्ता, आपका सुझाव.
क्या करना चाहिए आपको क्वेश्चन गवर्नमेंट अगर गवर्नमेंट पर्सपेक्टिव से बात करूं कि क्या करना चाहिए सी मेंटल हेल्थ में कोई फंडिंग नहीं हुई है सालों से इनफैक्ट इंडिपेंडेंस के टाइम पे अभी भी जो करंट हमारे लेवल्स हैं हेल्थ बजट है इट्स अप्रोचिंग 2% बहुत ही धीरे धीरे करके ऑफ द टोटल बजट और उसका जो हेल्थ बजट है उसका मेंटल हेल्थ पे कितना खर्चा होता है लेस देन 1%. हमने बहुत बात करी कि बहुत सिग्निफिकेंट एस्पेक्ट है मेंटल हेल्थ बॉडी पूरा कंप्लीट हेल्थ का बट खर्च कितना करते हैं 1%. सो वी नीड मोर गवर्नमेंट फंडिंग ऑफ कोर्स द गवर्नमेंट कैन नॉट अलोन डू इट. So we need more budgeting, more funding, investment in mental health.
Right. And that's the clear agenda which the government should work on.
Of course.
एक वो चीज़ जो बदलाव आप चाहते हैं.
I think, जैसे Dr. Parikh ने कहा, it's about the community becoming the mental health advocates. That is the major change that we need. We psychiatrists, psychologists alone cannot tackle the mental health of such a huge nation. And we need each and every person, social media influencers, they should talk about mental health in their various social media posts, the celebrities, the influential persons, the politicians, everyone needs to talk about mental health and make conversations about mental health normal. They should not be seen only on, say, we have different days. We have World Mental Health Day, we have World Schizophrenia Day, Autism Awareness Day. So our conversations mostly revolve around these days. There will be a major event on these days, and then we'll talk about mental health, and we'll forget after a few days. Right. So it has to be a continuous, ongoing effort. There are no days. Every day is a mental health day, I would say.
Every day is a mental health day, and the mantra is unmute yourself, talk to people, don't be limited to your rooms and your digital devices. Thank you so much for this great conversation, and this conversation should carry on beyond this platform too. We are now breaking into a quick lunch break. Our conversation on our health concerns will continue post this break. So don't go anywhere. I will be right back with our next panel. So enjoy your lunch and be back right here. Thank you so much. request everybody to quickly settle down so that we can start our next panel discussion. As India moves towards the ambitious vision of Viksit Bharat 2047, one thing is clear, हर समुदाय तक सुलभ और समान स्वास्थ्य सेवाएं पहुंचाना हमारी सबसे बड़ी प्राथमिकताओं में से एक है. Community health is not just about hospitals and medicines. ये sanitation, पोषण, स्वच्छ पानी, रहन सहन और मानसिक स्वास्थ्य जैसी कई सामाजिक पहलुओं से भी जुड़ा हुआ है. Bridging the rural-urban healthcare divide, breaking the stigma around mental health, and building strong primary healthcare systems. These are just not challenges, but opportunities to transform India's health landscape. इसी पर चर्चा करने के लिए हमारे साथ एक बेहद ही खास पैनल डॉक्टर सुनीला गर्ग, फॉर्मर डायरेक्टर प्रोफेसर कम्युनिटी मेडिसिन मौलाना आज़ाद मेडिकल कॉलेज एंड हॉस्पिटल, डॉक्टर धनंजय सागदेव, चीफ मेडिकल ऑफिसर स्वामी विवेकानंद मेडिकल मिशन, और डॉक्टर संजय राय, प्रोफेसर सेंटर फॉर कम्युनिटी मेडिसिन एम्स. आप सभी लोगों का बहुत बहुत स्वागत. अ वार्म वेलकम टू दिस प्लेटफॉर्म. Dr. Sagdev, let me start with you. You have been a living example and leading by example that community health care has to be one's priority. Tell us about your journey. What made you do what you're doing right now?
Well, thank you very much, NDTV. I am associated with NDTV's Banega Swasth India. So with this aim of NDTV, we are also working in Wayanad with Swami Vivekananda Medical Mission for last 50 years. I went there in 1980. You can imagine the situation of a tribal area 50 years ago. When I went there, absolutely there was no facilities for education, no health facilities, and basically Wayanad is a tribal area, and 80%, 20% of this population is living in deep forests. At that time, because there is no communication facilities, they were detached from the mainstream. So there was the main difficulty when we started a small clinic for our betterment of health of tribals. When there are two problems. When I went there, actually we cannot go to the tribal villages also. And there was accessibility with them, and then no, they will not allow the foreigners or outsiders to come to their colonies. They will not trust outsiders. And then they were on, for medicines also, they were not ready to take medicines also. So all these challenges were there. So we had to find out ways and means to see that we get access to them. They feel that we are one among them. They have got trust, believe in us. So we gradually started visiting their tribal villages. Then we found out that so many problems are there. So gradually we found out what can be done. And in last over 50 years, we have formulated one program. We thought that we should have a total development program for our Vanvasi brethren. So we have developed 5-point program on Swasthya, Shikshan, Sanskar, Samajik and Swawalamban. On these 5 program points, we are doing so many activities that I will tell afterwards.
Right. So you are leading by example. Dr. Garg, Dr. Sagdev is leading by example. He took that initiative. But आपको लगता है जो हेल्थ केयर सर्विसेज हैं ग्रामीण और अर्बन क्षेत्रों के, उसका जो डिवाइड है, उसका जो डिफरेंस है, जो अंतर है, क्या वो कम हुआ है, वाकई नैरो हुआ है क्या ये डिवाइड?
I think thank you so much for a very important question. Like Dr. pointed out, I also have my foundation from rural area. I did my MBBS and MD from Mahatma Gandhi Institute of Medical Sciences, Sevagram, right, which is a rural medical college, and did my MD in 82. And at that time, then the health minister, Dr. Sushila Nair, was my guide also. So, and all now I can say from the government's perspective, lot of initiatives from ICMR's perspective, they are being focused towards rural areas, tribal areas and all that. Now coming to your question, that we have got now nearing, 1,60,000 Ayushman Arogya Mandirs which are functional, right? And they have come out of where? They have come out of sub-centers and also primary health centers, right? So, and we have got, basically not only, I'll say that there is presence of infrastructure over there, there are, since we are, I'll say that we are 146 crore people. It's not easy, divided over 36, states and union territories. Definitely there's a challenge. We are still coming up a big way. I will still say, but we have made a lot of progress in the direction of Viksit Bharat in terms of Ayushman Arogya Mandirs, that having, above them we have got, that means comprising of our sub-centers, primary health centers, and above that we have got community health centers, and then sub-district and district hospitals. And plus, we cannot underscore the importance of private infrastructure. Definitely it is less. We do have a skewed distribution, definitely, and I don't blame people will say that doctors jaake urban areas mein rehte, kyun rehte hain basically? So because, you see, it's not only they themselves, but it's their families also. Very few will be like Dr. Abhay Bang and Rani Bang, because they have been very close colleagues of mine. Rani was my registrar, and they're working in tribal areas. Their children are there. So that kind of zeal, gradually it is coming, and I'll say many of my colleagues, they go and do the internship over there. But definitely, when we look at PM Abhim, that is Prime Minister's, healthcare infrastructure mission, or when we look at the service delivery, we are focusing on Ashas, Anganwadi workers, ANMs. Along with that, we have created a cadre of community health officer, which is, a BSc nurse, and which has been, now, earlier we had a 6 months training separate for her, and those of you who are not aware of that, BSc nursing itself is now incorporating this course of community health officer. So in terms of capacity building, leadership governance, system strengthening, all are priorities for Viksit Bharat. So that is where we are moving in this direction. It will take time. We never heard of earlier talking of telemedicine and all that. Now we are talking of telehealth, telemedicine, which are important. So these things are a step towards Viksit Bharat, and we are moving in that direction. Thank you.
Right. Dr. Rai, talking about solutions, we are still living in India where clean drinking water is still not a guarantee. Basic sanitation is one of the challenges. So how do we fix these basic issues before we talk about community health centers reaching the people who are living far and wide?
I will start with first the gap between the
urban and the rural.
Urban and rural, and then definitely to the sanitation and other. See, no doubt this gap is narrowing down. But still, if you see any health indicator, either infant mortality rate, under 5 mortality rate, life expectancy at birth, all are lower, still lower in the rural area. But it's not only rural, urban. Even in urban, if you compare urban poor, there are some pockets in urban area. And if you compare these urban poor with the rural population, then all these indicators are worst in these population. So urban poor. Yeah. So it's a 3-step: urban poor, and rural. And the gap is definitely there. One of the main reason of this gap is accessibility is the main issue.
If you see the doctor population ratio, it's more in the urban area.
Ji.
Then there are social determinants, social factors are responsible for this. Even in this country, if you compare the various health indicators, in the same city, for the different population, it's different. So there are many social issues. They are playing important role. Coming to your the next question related to this sanitation and also your
clean drinking water.
Clean drinking water. Even forget about rural area. Even in the urban area, we are facing problem. It's very difficult to tackle this problem. Somehow sanitation is not up to mark, although the Pradhan Mantri started this Swachh Bharat mission long back when first time he came in the power in 2014 on 2nd October 2014. Pradhan Mantri ne start kiya tha isko with ambition that we will make this India completely this free from what we call open field defecation. That was a 5-year target, but still we are struggling. So there are many issues, and all these are, it's not a medical issue. Mainly social issues. So these are the social issues, they are playing the important role. Education is one of them. Even a government is providing some basic facility, but many are not assessing that facility. So clean water is a problem. How to address this issue? Already this government has started one more program to provide clean drinking water to each and every individual of this country. But really that program is still not up to mark.
Right.
So the basic sanitation, drinking water, if you see the prevalence of waterborne diseases, typhoid, cholera, many waterborne diseases, even your, we controlled polio. Polio is also waterborne disease. So still the incidence and of these diseases are very high in this country. So we are unable to make sufficient dent on these diseases, and mainly because of the
these issues which need to be tackled, which you think is a big
Definitely.
social issue which needs to be tackled at a very
these are the mainly social issues.
बिल्कुल बिल्कुल ये social issues है. डॉक्टर सागदेव, क्योंकि आप उन इलाकों में काम करते हैं, इसलिए it's important for me to ask you that क्या हम आदिवासी और दूर दराज के इलाकों की स्वास्थ्य ज़रूरतों को एक देश एक समाधान से हल कर सकते हैं, और we need regional policies or specific policies area wise?
Yes, that is the main issue. जब हम पॉलिसी बनाते हैं तो इन्हें बोलना ना चाहिए दिल्ली में बैठ के जो they are not visited the actually rural or tribal areas, what are the basic difficulties. So हमारा जो मानना है कि जो पॉलिसी जब बनती है तो लोकल एरिया में और जो ट्राइबल्स के जो स्पेशल कल्चर है, उनके जो बिलीफ्स है, उनको विचार करके उनको जो समझ में आएगा उस तरफ से यदि बात करते हैं. इसके लिए हमने जो हमारी स्वास्थ्य मित्र स्कीम है, हेल्थ वर्कर, सो बेसिकली एवरी कॉलोनी और ट्राइबल एरिया में यदि हम अच्छे हेल्थ वर्कर करते हैं, उनको ट्रेनिंग देके दे लुक आफ्टर देयर नीड्स ऑफ द हेल्थ, देन if we say ASHA workers also government machinery, they should be sensitized that because just because there is tribal and non-tribal divide actually in fact in our country, and tribals are looked down that they are not equals with tribes. So non-tribe health workers also tend not to look after the tribal areas properly. So जब policy बनाते हैं तो जो sensitization of the health workers है and creation of health infrastructure with the special needs of the remote areas should be there. What we are doing, these three types is there. Solution I am just telling. One is the Swasthya Mitra who looks after the tribal colony.
Right.
Next is, we have started this clinic on wheels and with telemedicine. So it takes health professionals, and then if for specialty care, the telemedicine unit works with the health Swasthya Mitra, with the specialist in our hospital. So that solves the problem of specialty care. Third will be taking the patients to the hospital, because many times the tribals or this so many rural areas, there is communication gap, transport problem. So ambulance care is most important. So many times in Wayanad also, the tribal pregnant ladies, they get delivered in their colonies itself or in vehicles before reaching the hospital. So transporting the patient to the hospital is most important. Then getting the good health care for them in the hospitals also. Because they are not aware what is available, then socio-economic problems. So all this should be the policy, holistic approach, so that the health problems of rural and tribal areas.
So you're saying that we have to be very region-specific and area-specific, and that's the way to tackle the issues which are around the interiors of the country. And you are saying that sitting in Delhi, we can't be making policies for the interiors of India.
Yes.
Dr. Garg, जो अच्छा कम्युनिटी हेल्थ का एक बेसिस है, जहाँ हमने बात की क्लीन ड्रिंकिंग वाटर की, वी स्पोक अबाउट सैनिटेशन, द अदर एस्पेक्ट इज न्यूट्रिशन. You know, that has to be the basis for a healthier India. And what do you see, the nutrition programs, what are the challenges we are facing on that front?
Yeah, before this, I'd like to talk a little bit about the tribal population, because I've been associated with 4 major this thing. One is AIMS Devghar, where, you know, we do have substantial portion of tribal population, and it is also known as Center of Excellence. And why it is a Center of Excellence? Because it is dealing with that kind of population.
Right.
And, you know, understanding that population. The second part is, you know, second Center of Excellence is AIMS Jodhpur, where, you know, again, you know, the focus of the government now is, and also all of us, because most of us, we come from the community medicine background.
Right.
Now we don't talk about top-down approach, we are also talking about bottom-up approach. So we are doing macro planning and all that, and we are encouraging our workers. It is not like earlier times that you go for sterilization, do that much number of sterilization and all that. And the third project, Doctor, which we are dealing is with regard to, you know, preconceptional care in tribal population. तो हमने क्या realize करा, conception तो तब होगी जब हमें वहाँ के marital norms मालूम होंगे, वहाँ marriage होती है, कब होती है. So that is how, you know, they are working with the district health authorities, the National Institute of Reproductive Health, you know, in Mumbai, that is also working. And then plus another is AIMS Gorakhpur, where, you know, now focus is on tribal population, understanding their needs, and accordingly, we are also posting our Indian medical graduates now, which are about 100,000 in numbers. We cannot give the same, you know, exposure to all of them, but that part is important. Coming to the second part, you know, when you talk about malnutrition, you see, nutrition is the backbone of country's development. When we talk about malnutrition, we are not talking about only acute malnutrition, we talk on chronic malnutrition, we talk on acute and on chronic malnutrition. And now, you know, we have got different, you know, kind of initiatives, like from Poshan 1, we have moved to Poshan 2, and we are seeing that, and we are also focusing basically on the, you know, the challenges are very big. Let me tell you that it is not so very easy that what we talk about, you know, the availability of food, we tell our Anganwadi workers to provide food and all. Substantial proportion, you know, our NFHS data also brought out, you know, that we do have high number of children with malnutrition. So we have to take care of that. Again, we did the reassessment and all that. But problem is that the malnutrition does exist. But how, you know, basically that's where, and we are not talking about acute, we are talking about severe malnutrition, SAM, where we are talking about. So that is where, you know, different initiatives have to be implemented in true spirit. That part is very important, and this is where Anganwadi workers alone cannot do a job. It is basically the education of the family, because one part, you know, it is supplementary nutrition, can be done by, you know, the ICDS scheme and all that, but important is the empowerment of the families, their education, because we cannot say that you take nutrition and rest of the family shares it, you know.
Right.
And we started giving this in the Anganwadi itself, but you see, we cannot, looking at the diversity and the as again I said, looking at the population and looking at the huge number of population, the work is challenging and it all falls upon, I'll say, one Anganwadi worker. When we say about 1,000 population, and in practice they look after, some of the Anganwadis are looking after much more population.
Yeah.
So it is education, it is, again, I will say, not only health or education or ICDS, together we have to work more in this direction, and this is where our Panchayati Raj institutions and all together have
they
to,
can play an
we
important
have
role
to
in
play
implementing.
we have to play a very important
Bilkul.
education of our school children. That how, you know, it is very important,
Right.
you know, so we had created polio unmulan sela, you know, to take care of polio.
Right.
Similarly, we talked during COVID times, involve children and all that, you know. Education of children is also very important. Family education
So you're
is
saying
important.
implementation,
Yes.
awareness. You wanted to add something, Dr. Sakdev,
Yeah,
before I go to
Dr.
Dr. Rai. Ji.
Malnutrition actually really is a very big problem, a major problem. And it is not only nutrition problem, it is a socio-economic problem. Because most of these malnourished are women and children. The matter of fact is that the male people, they will go work, earn money and spend their money on alcohol and drugs. And they don't look after their families. And the women, they will work, they will earn something and look after herself and her children. Because of ignorance, they will take only some rice or something. So both ways, socio-economically, they don't know what to take. There is no availability and support from the male members. And children also, whatever is available, because there is absence of knowledge of what to take. So actually, good natural, actually it is available in Wayanad or rural areas, but they will take only rice or something. So the solution is that awareness, and then now schools also, in our schools, we are doing this midday meal, and daily we are, so that it is both way, incentive to, because education, there is another problem, dropouts of tribal children and not continuing their education. So giving food, healthy food in the lunchtime, there is actually one scheme, morning breakfast we are giving, lunch also we are giving, evening snacks also giving. So that is an incentive, giving good food and incentive for studies also.
Study and food, they go together.
Yes.
And that's the way forward. इस पैनल डिस्कशन से पहले डॉक्टर राय, एक हमने जो दूसरा पैनल डिस्कशन किया वो मेंटल हेल्थ पर था. एंड इट वाज लाइक डिस्कस दैट प्राइवेट सेक्टर तो छोड़ दीजिए, पब्लिक सेक्टर में सरकारी पहल में बहुत कुछ काम हो रहा है मानसिक स्वास्थ्य को लेकर. ऐसे में क्या ये डिवाइड आपको वाकई कम लग रहा है और इसकी प्राथमिकताएं हैं क्या? कम्युनिटी हेल्थ सर्विस की जब हम बात करते हैं तो मेंटल हेल्थ उसमें कहाँ ठहरता है?
See, mental health is a really big issue even in this country. There are few indicators. There are few direct indicators, few indirect indicators. Direct indicators like your overall depression, anxiety in the community, so prevalence of these problems. So there are very few direct indicators. There are indirect indicators like suicide rate. This is a mental condition which ultimately lead to suicide. Homicide rates, alcoholism, drug addiction, all these are mental issues. We have a national program to tackle these mental issues. So definitely it's a big challenge. The majority of us are aware, many our farmers, last year if you see, more than 2,000 farmers, they committed suicide. So suicide is one of the issues. Ultimately, it's a status of your depression. This is the last stage. So you are unable to cope up with that problem and then taking this step. So definitely mental health का issue है. गवर्नमेंट उसके लिए कोशिश कर रही है, बट उसके लिए जो है थोड़ा सा अगेन सोशल रिस्पॉन्सिबिलिटी भी लेनी पड़ेगी, कम्युनिटी को पार्टिसिपेट करना पड़ेगा. सो कम्युनिटी पार्टिसिपेशन इज वन ऑफ द इम्पॉर्टेंट इशू इन ऑल द नेशनल हेल्थ प्रोग्राम्स. It's hardly matter, it's a top-down approach or bottom-up approach. Now, under our current national health policy,
government released in 2017. Almost all programs are now bottom-up approach. Right. So not from the top, they are making all these national health programs and going down, no. All the community level worker, they are preparing a program for themselves and then to the district, to state, and then finally to the center. So almost all in all national programs, this is the current approach. But definitely it's a mental health issue is a big issue.
Bilkul, and a lot needs to be done on that front
Definitely.
too, right? The other aspect around community health services and its programs are women. You know, the basis of forming those policies and programs is around women. स्वास्थ्य सेवाओं तक महिलाओं की पहुंच में कौन-कौन सी चुनौतियां इस वक्त हैं और जो अर्बन पुअर हैं और ग्रामीण इलाकों की महिलाएं हैं उन तक पहुंचने में सेवाएं कितनी अभी तक समर्थ हो पाई?
Again, I'll say thank you for asking this question because gender-based issues, when we call it as gender-based issues, it's a big challenge still. क्योंकि आज भी अगर हम बात करें तो भारत एक पुरुष प्रधान देश है. हमारे यहाँ अगर हम डिसीजन मेकिंग की बात करें, डिफरेंट स्टेट्स हैं हमारी and they're very different in their decision making, whether it is related to health, whether it is related to food intake, whether it is related to their common illnesses. जैसे हम reproductive illnesses की बात करें, वो कहेंगे अस्पताल क्यों जाना, क्योंकि discharge एक बहुत common symptom है. किसके लिए? इसके लिए every woman has a discharge, so I have a discharge. What is the big problem? Because and they are not able to understand, so communities are also not able to understand, families are not able to understand. That is the first thing. The second part is that, you know, they, not only husbands, it's the family which makes the decision for them. So, you know, everyone learns from that, okay, I also had a, you know, delivery at home, what is the problem? So initially we had that challenges. So we thought of bringing out this Janani Suraksha Yojana and all that. But women empowerment is one of the major issues. And when Dr. Sanjay was discussing about mental health issues, in women, you'll see they are so much undisclosed. So that is where that important thing is also very much in place, and we cannot ignore that whole issue. And we see that, you know, now what surfaces is that that many students going to a particular state for engineering are committing suicide, or we see high rate of, you know, anxious children, you know. So all these things have started coming up early. But important is that and if you will see our Ayushman Arogya Mandirs, one of our major things which we have been doing from the beginning was only women and child health services. Now we have added to them 10 health services, which includes mental health also. But being gender sensitive is very important, number one. Providing accessible services. Accessible services means not only care part, preventive, promotive, and curative. That is very important. Regulating the family size is very, very important. Taking care of their nutrition. It's usually seen that she's still the last eater in the family. So that part is very important. And I'll say to all my women friends who are sitting over here, that be sensitive to the needs of the women. It's not, if we are not sensitive, men are not going to be sensitive. We have to see that how we can support each other. Please, we do not forget, you know, that there are basic needs. Still, when a woman, she's working, it's a dual load. Right. You know, she goes back home, whatever position she is, there is a house responsibility which is weighing upon her. So, you know, somewhere we have to see that we are gender sensitive, we are gender friendly, and our services, when we talk of flexi hours and all that, that part is very important. She is able to make decisions which has to be understood, and that will only come when we talk and when we provide, you know, that kind of information on a regular basis. That kind of
environment for them to keep talking about it and keep talking about themselves, right? We're coming towards the end of this discussion, and my question to all three of you, since you all are experts in this field, in the vision of Viksit Bharat 2047, since we are talking about solutions, क्या हो सकते हैं, समाधान क्या है community health service, सब तक पहुँचे और हर एक इंसान तक पहुँचे जो कतार में आखिरी खड़ा है. How do we build a health system that is inclusive, preventive, and truly community-centric? Dr. Sagdev, we start with you.
When we say it is a Viksit Bharat 2047, it should be all-inclusive, and it should be a holistic approach And for betterment of health of our everybody, we should have comprehensive health policies so that it reaches everybody, includes local communities taken into their cultural beliefs, and it is helpful to them and to the society, so that just what our Prime Minister is saying, सबका साथ सबका विकास, so that we can develop together.
Dr. Roy, एक प्राथमिकता जो जरूरी है इस वक्त.
See, in our country, we have three-tier healthcare delivery system, primary, secondary, and tertiary. Strengthening primary healthcare system is the single most important factor for this Viksit Bharat 2047. And this should be the objective of the government of
Primary
India.
health center को और ज़्यादा मजबूत बनाने की ज़रूरत है.
बिल्कुल. प्राइमरी हेल्थ केयर को जितनी हम स्ट्रेंथन करेंगे, टर्सरी केयर पे लोड कम होगा, वी कैन मैनेज. हमने कोविड के समय देखा रूरल एरिया में अगर हम वहीं पे सर्विसेज प्रोवाइड कर सकते थे, सो डेथ कम होगी. सो स्ट्रेंथनिंग प्राइमरी हेल्थ
should be the priority
first, and the second one is proper implementation of our program. We have very good programs. चाहे वो टीबी कंट्रोल हो, HIV एड्स कंट्रोल हो, मलेरिया हो, all this, a proper implementation of the national health program. The policy are very good.
But
all
implementation की ज़रूरत है.
The issue is, problem is in implementation.
So, we all know that there is something known as National Health System Resource Center. So, what Dr. Sanjay pointed out, so comprehensive primary health care, in true spirit, we should be implementing all the 12 task forces, and nobody talks about, palliative care. So with the increase in life expectancy, we need to see that. The second part is that when we also, I think many of you would not be aware, recently, about 15 days back, there was a meeting in the ministry regarding strengthening of our community health centers. Community health center is the first place where presence of specialists is there.
Right.
Why we need to provide emergency obstetric care, the presence of availability of blood, but they are now also going to look after trauma care also. That part is important.
Right.
So, sabka saath, sabka vikas, ye bahut zaruri hai. We need to be inclusive and we need to take everyone with us. And now the last mile has become first mile. So that should be our approach. Thank you.
सबका साथ सबका विकास तभी संभव है जब कम्युनिटी हेल्थ सर्विस सेंटर स्टेज ले. बहुत शुक्रिया आप सभी लोगों का. Thank you so much for joining this panel discussion. We end our session here. So before we end our day, a big thank you to the audience, our panelists, and our sponsors. Let me take this opportunity to thank our sponsors who made this summit possible. NDTV India Health Mission Season 2 is presented by Fortis Healthcare, co-powered by Takeda Pharmaceuticals, nutrition partner Herbalife, supporting partners Norton Das Realty, and IDFC First Bank, associate partner Shell Cal 500. Thank you so much, and thank you for taking out time for this very important discussion throughout the day. Thank you. Thank you.
The thing about greatness is that it doesn't recognize age.
As a part of
It does not wait.
As a part of our health campaign, we are running a blood donation drive right outside this place. So if anybody is willing to join this good cause, please feel free and reach out to our teams outside who are waiting for this blood donation drive. Thank you.
The thing about greatness is that it doesn't recognize age. It does not wait for the right moment. Greatness only comes to the